fashion. Can I welcome everybody to the 8th hearing of Portfolio Committee number 2's inquiry into health outcomes and access to health and hospital services in rural, regional and remote New South Wales. My name is Greg Donnelly and I'm the chair of the committee. The inquiry is examining health outcomes, access to services, patient experience, planning and capital expenditure in rural, regional and remote New South Wales. Before I commence, I would like to acknowledge the Winjabal people and the Bundjalung people who are the traditional custodians of this land. I would also like to pay respects to elders past, present and emerging of the Winjabal people and extend to that respect to other Aboriginal people present here today or joining us this afternoon or maybe joining us on the internet. Today we're hearing from a number of stakeholders including local community groups, private enterprise, private citizens and the local health district. I thank everyone for making the time to give evidence to this important inquiry. Before I commence, I'd like to make some brief comments about the procedures for today's hearing. Today's hearing is being broadcast via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available in a couple of days' time. In accordance with broadcasting guidelines, media representatives are reminded, and I welcome the media who are joining us now and maybe joining us over the course of the rest of the day, that they must take responsibility for what they publish about the committee's proceedings. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside their evidence at the hearing, and I therefore urge witnesses to be careful about comments you may make to the media or to others after you complete your evidence to the inquiry. Committee hearings are not intended to provide a forum for people to make adverse reflection on others under the protection of parliamentary privilege. In that regard, it is important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness according to Procedural Fairness Resolution of the House of 2018. If witnesses are unable to answer a question today and want more time, they can take that question on notice. Written answers to questions taken on notice will be provided back to the Secretariat within 21 days. And finally, if witnesses wish to hand up documents, they should do so through the committee staff who are here to support us. In terms of audibility of the hearing today, I remind both committee members and witnesses to speak into the microphones. There's 2 microphones before you. One's actually for the audio, for the sound in the room, and the other one on tripods for Hansard. So that's what the 2 microphones are for. And finally, could everybody please turn their mobile phones to silence for the duration of the hearing. Can I, before going any further, acknowledge, as I ought to and as appropriate, the member for Lismore, Janelle Safford, who welcome Janelle, very well-known member and hard member, a working member representing the most important electorate of the North Coast up here in Lismore. It's great to see you, Janelle, and your staff as well, so go come and see you. And Ryan Park, the Shadow Minister for Health, is joining us today with staff, so you're welcome. There are and will be representatives of New South Wales Health, as they have done, came in and visited over the course of today, so they are welcome. And of course, and importantly, members of the public. It's great to see members of the local community in Lismore and more broadly coming along to this public hearing today. It's great to see you. So we'll welcome our first panel of witnesses. Thank you so much for agreeing to come along. The contribution of evidence from witnesses to inquiries is vitally important, and inquiries would be much impoverished without people like yourself agreeing to come along and give evidence, so thank you very much. So what we'll do is the formality of having you sworn or affirmed before you give your evidence. So starting from my left, Ms Fletcher, I'll ask each one of you to just announce your name, your position, title if you're representing an organisation, but if you're here in terms of being a citizen, private citizen, just declare that, and then swear either the oath or affirmation, whichever you prefer, the words of which are before you, and you can make that choice. So we'll start with you, Ms Fletcher.
Thank you. I'm Maureen Fletcher. I'm the chair of the Ballina Cancer Advocacy Network Committee. And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much. Mrs Grundy.
My name is Marilyn Grundy. I'm president of the Alban Elbow branch of CWA. And I'll swear an oath.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Mr Thompson.
My name is George Thompson. I'm a member of the Coraki Health Reference Group.
Thank you.
And I'd like to acknowledge the presence of two other members of that group here today,
Please do.
Carol Hill and Susie Carey.
Thank you.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. And joining us by teleconference, and you can't see her, but I can assure you she's there, here, right on my right-hand side, is Mrs Sharon Bird. Welcome, Mrs Bird.
Thank you.
Mrs Bird you heard my introductory comments about the announcement of your name, your position, title, and the oath of the affirmation?
Yes.
Yes. And you have the words for either the oath or the affirmation there for you to read?
No, I haven't received any from you, but I've got one in front of me, which should be fine.
Okay, good. Well, I'll get you then just to go through your name, title, and then
Sure.
swear either the oath or affirmation. So, Mrs Bird.
Okay. My name's Sharon Bird. I'm the pharmacist at the Melbow Pharmacy.
Thank you.
I solemnly and sincerely declare and affirm that the evidence I will give shall be the truth, the whole truth, and nothing but the truth.
Thank you, Mrs Bird. Appreciate it. So, can I just, for the record, note and confirm that you've all made submissions to the inquiry. Mrs Grundy, your submission stands as submission 278. Mr Thompson, you and your organisation, submission 179. Mrs Fletcher, yours is 184. And Mrs Bird, very enthusiastically, two submissions from you, 347 and 423. Now, those are obviously to be read combined, so thank you for that. They've all been received, processed and stand as submissions to this inquiry and have been uploaded to the committee's webpage, so they're there. I raise that specifically because I'm going to invite you all now to make an opening statement, and in saying that, you don't need to read your submissions again out, or part thereof. Simply set up, if you wouldn't mind, the key points that you wish to present to the committee today at this hearing, and then enable us with the maximum time as committee members to go through questioning of you. So I'll give each of you, one at a time, a chance for an opening statement. 3 or 4 minutes would be great if you could keep that to a max. And if you've got to do a bit of editing as you go through, that's fine. So we'll start with Mrs Fletcher.
Thank you. Ballina Cancer Network Advocacy Committee would like to thank the committee for this inquiry. Cancer care is complex and there's no simple answer to improving care. Ballina Can was established with the support of Cancer Council to be a voice for the needs of the region. Our market research in 2012 highlighted huge differences. Much has changed with improved medical treatments here in the hospital. However, the missing component is care. That is mental and emotional care. Most cancer patients feel traumatised when hearing the words, "You have cancer." Our submission advocates for a dedicated care coordinator to be available to support all cancer patients. That is, men and women. This care person to be available at the hospital during treatment and out in community post-treatment. We hear comments like, "I was overwhelmed, I felt totally alone." And, when I heard the news, I just thought I would die. Support is needed. Support for the mental impact of diagnosis, the psychosocial needs of the patient. And support is needed to gain knowledge of what services are available, services needed both during and after treatment. The submission draws on case studies and anecdotal evidence where patients have needlessly suffered because they were not aware of what was available. And you can refer to some post-studies that I have put forth to be tabled.
So just confirm that, so we all understand. This document here, which has on the first page case study number 1,
Yep.
with some statement of additional pages. That's the document we're referring to.
That's right, sir.
Thank you.
Right. So just to highlight a couple, we had a man had melanoma and had half a nose, and so he was socially isolated. He only found out that a prosthetic nose was available when a fellow patient asked at hospital why he didn't have it. This highlights the gap within the hospital outpatient system. Also, a woman, after having a breast lumpectomy at Gold Coast, returned to Byron. Next day, having issues with her wound, went to Byron Hospital. No help was available at all, and the Tweed breast nurse did not return calls. This highlights the gap within community. These two cases are only representative experiences that we hear from people all the time. For myself, I had breast nurse and joined a support group, and still I struggled at times. I had never been to hospital before in my life. My treatment took 16 months, and that's a lot of chemo. And I don't have family and I don't have children. And I'd only been in the area for 2 years. Breast cancer has a strong support service outside of the hospital system. The McGrath nurses have a high profile and they do a wonderful work. Our submission advocates for a dedicated cancer coordinator to work alongside current staff, such as social workers, to support both men and women, be they be an inpatient or an outpatient, and when they're back in community. This position would ensure equity across all cancers. In the northern New South Wales, the 4 biggest cancer diagnoses are firstly lung, then prostate, colon, and then breast cancer. And only breast cancer has a dedicated nurse. And if your diagnosis was one of the lesser known cancers, who would you turn to? A cancer care coordinator would be the point of contact in the hospital or in the community for emotional support, as well as a point of contact for the diverse services available, but yet unknown by the general public. If we wish to improve health outcomes in our regional areas, we need to improve care. Thank you for your time and this opportunity to speak on behalf of our community.
Thank you, Ms. Fletcher, for an excellent opening statement, very precise, clear and on point for us to be able to ask you some questions. Would you mind, if our Secretary liaise with you over obtaining a copy of the opening statement to assist Hansard with the transcription? That would be great. But no, that was excellent. Mrs. Grundy, would you like to make an opening statement?
Good morning, honourable members. I'm Marilyn Grundy and I'm representing the views of members of the Alban Elbow branch of CWA in the Upper Clarence Valley. We live in a long, narrow valley bordered by ranges, with the only roads being in the north and south out of the area. The area covers Alban Elbow, Urbanville, Benalbo, Tabulum, Malangany and Drake. We are a community of many rural properties and smaller holdings with a large number of senior and lower income earning people. We also have a large First Nation community. I would like to thank and acknowledge all who have provided our MPS after closure of the hospital in Benalbo. We have a good doctor who comes out regularly and stays in the town for 3 nights. He is here 4 days per week and is fully booked. He is available for phone consults, for a script clinic, telehealth and support to ED and inpatient at prescribed times. During the interim between the closure of the hospital and the new MPS being built and a doctor being found, most people had to go to Casino or Lismore. Even now some people give up going to the doctor because of wait times, distance and inability to actually attend due to travel, and it all gets too difficult. I have had no medical training, but I feel that I can recognise when medical care could have been provided differently. Our members believe that healthcare outcomes can be improved by overcoming some of the barriers that are imposed by geographic isolation and unpredictable and rudimentary exposure to healthcare professionals. Clients who suffer with chronic illness and those with varied complex needs are generally travelling at least 70 to 100 k's plus and travelling for various amounts of time, which can be in excess of 3 hours, to access private or public allied health services with almost no or unreliable public transport in our area. Our main problem that we are faced with is, at the moment, it is like we have one slice of bread instead of a sandwich containing a nourishing and sustaining filling. We have our MPS and doctor with good staff, but could do better with more allied health professionals, another doctor who fills in for when our current MO cannot be there, and more staff with extra qualifications, e.g. nurse practitioners, fleck nurses, etc. I have tabled a folder,
Yes,
which I think has been given out.
it has, yes.
And yes, I also wish to thank you for listening to me.
We are very grateful that you've made yourself available to come along today, Ms. Connie. And
Thank
thank
you.
you. It's an excellent opening statement, and I acknowledge the receipt of the folder. I think all honourable members have a copy which contains that statement.
Yes.
That's supplemented by then a number of additional pages with some quotations and some tables and what have you, which no doubt we'll come to when we get the questioning. So thank you very much.
Thank you.
Mr. Thompson.
Thank you, Chair.
Welcome.
Coraki needs a doctor. We're a community of 2,000 people, 30 k's south of Lismore. When I first visited Coraki 25 years ago, there was a hospital and 3 doctors. Now we have no hospital and no doctors. The hospital in Coraki, which is called the Campbell Hospital, after the local benefactor John Campbell, who founded it in 1904, was closed in 2011 following storm damage to the building. And the North Coast Area Health Service, as it was then known, decided not to undertake the repairs, not to reopen the hospital, but to redirect the resources elsewhere. Generations of local residents have been cared for in that hospital. Many of them were born there, many of them died there, many of them found employment there. So the loss of the hospital is still keenly felt in the local community. With the closure of the hospital, the Northern New South Wales Local Health District instituted a process to develop a clinical services plan to determine how the health needs of the community could best be met. And that plan recommended the establishment of a Health One facility in Coraki. The Health One was duly built with funding from the New South Wales Government, and it was opened in 2017. So we now have a very nice state-of-the-art facility, Health One facility in Coraki, which offers a range of community health services. It offers community nursing, physiotherapy, occupational therapy, speech therapy for children, women's health, chronic disease clinics, even from time to time oral health. But the members of the committee would be well aware that the essence of the Health One model is co-location of general practice with community health services. It's an integrated and multidisciplinary model of care. It's the GP who directs the care of the patients. It's the GP who makes referrals to the allied health professionals in the centre, and it's the GP in collaboration with those allied health professionals who monitors the progress of the patients. But in Coraki, we have a Health One with no GP. We have rooms for 2 GP practices, but those rooms are empty. We feel we have a Health One without a heart. And we know that this problem of a lack of GP in small rural communities is not unique to Coraki. In fact, I've had a look through the submissions to this inquiry, and I can tell you the following submissions all draw attention to the absence of a GP or chronic shortage of health professionals. Benalbo, Eurobodalla, Gunnedah, Deniliquin, Edward River, Manning Valley, Port Stephens, Temora, Glen Innes, Gulgong, Wee Waa, Wallandilly, Mid-Western Regional Council, Collyamberley, Warren Shire Council, Broken Hill, Wentworth, Merriwa, Tenterfield, Parks, Coonamble, Gwydir, Burke, Hay and Leeton. So this is a serious problem. It's crying out for solutions. I know lots of good work is being done all over the state in every LHD to develop solutions to redress this lack of medical professionals in rural areas. But I can tell you from our own experience in Coraki and from the submissions to your inquiry that that solution has yet to be found. And we look to you, our elected representatives and community leaders, to come up with solutions that will attract and retain the services of medical professionals in rural areas like Coraki. And in closing, can I just add that our group has also included a suggestion in our submission that a GP practice might be more attracted to Coraki if the Health One was converted into a multi-purpose service model in collaboration with the 49-bed aged care facility, which is located right next door to the Health One. And we've also called for the location of an ambulance in Coraki to cut down the turnaround time of 1 hour at best to get an ambulance from the nearest stations at Evans Head and Casino to the Lismore Base Hospital. If we had an ambulance in Coraki, we could cut that time in half. Thank you very much for the opportunity.
Well, thank you, Mr Thompson. And can I just say this, just a small segue. It's very impressive, I found, as we've travelled. We've been to a number of places around the state. Individuals like yourself from local communities identifying an issue and coming together and being extraordinarily intelligent and creative in coming up with proposals and ideas to deal with local matters. I mean, obviously the work that's gone into, dare I say, the research to understand the scope of the issue and then turn your mind to what are positive, intelligent, reasonable propositions for the state, and when I say the state, I mean the government, including executive government, is very impressive. And it struck me time and time again. We have people coming along from communities working with us to try and address the local issues, and I think it really reflects on the seriousness of the issue, number one, and number two, really falls on then those in the positions of power to listen and make appropriate decisions. So thank you for that. Now, Mrs. Bird.
Yes.
Can I invite you to make an opening statement? And if you could keep it reasonably short, that'd be great.
Sure.
Thank you.
Honourable members, I trained in pharmacy at the University of Queensland, and by the age of 25, I was chief pharmacist at Bundaberg Base Hospital. I bought my first rural pharmacy in 2002 and Benalbo Pharmacy in 2015. May I start by emphasising the great positive impact the new MPS has made in our area, which serves approximately 4,000 patients, coming from up to an hour away. Palliative care used to be a tremendous failing, with people left to die in their homes at a time when they needed IV pain relief and full-scale nursing care. By this stage, their carers are themselves ill and exhausted. This doesn't happen anymore, as we have 4 inpatient beds, including a palliative care suite. I can also point to greater efficiencies in our local GP practice, which operates out of the MPS. For years, there was a 3 to 4 week wait for an appointment, even as recently as my submissions at the start of the year. But recently, thanks to telehealth, prescription clinics and special clinics just for urgent GP cases, they are now achieving a lot with their limited resources. Many customers still see doctors elsewhere, but would like to be able to see a doctor locally if the capacity were there. Our worst problems occur over the doctor's 4-day break every fortnight and around public holidays and holiday leave, when he isn't always replaced with a locum. Pharmacists major in minor illnesses, and I can usually treat those, but when it comes to conditions requiring a prescription or conditions that need referral to a doctor, my role is to refer them on for appropriate care. If there are no appointments available for weeks and no emergency doctor, we are out of luck. I often encounter situations where people are in too much pain to travel over an hour or more over our rough roads to see a doctor in our larger centre. I can give several examples. We need a locum for holidays, or preferably a second doctor to fill the gap, and a cost-effective way to achieve this would be to have a rural generalist registrar 3 days a week under the supervision of our specialist, who is a rural generalist GP. We also have an X-ray machine, but no trained staff on site to run it. So we have a radiographer coming out for 2 hours once a fortnight. So we advise our patients to schedule their accidents for that day. Frustratingly, offers of scholarships to train nursing staff have been rebuffed by management. Finally, assuming that the goal is better health outcomes for rural patients, I offer barriers to people accessing healthcare in rural areas and possible solutions. Many of my customers have had negative experiences when accessing healthcare in the referral centres such as Lismore and Casino. Those who have previously waited 3 to 4 weeks and travelled for hours for an appointment in Lismore or Casino with no outcome, or who have had a previous bad experience, like being abandoned in Lismore in their pyjamas after an emergency ambulance trip with no way to get home again, are reluctant to seek help or call an ambulance again. It would help if people in these centres were aware of their local geography, and perhaps this should be part of job orientation. Our local roads are terrible, and the road conditions and weather conditions make travel to Casino dangerous, especially when in poor health. 2 of my customers have been seriously injured in accidents on the Bruxner Highway in relation to hospital or medical visits over the last 5 years, and there are regular fatalities on that stretch of road. Thick fog in the mornings and evenings, or driving into the sun in the early morning and late evening, add to the risks. We need appointments in the middle of the day if possible, and for imaging and other tests to be available on the same trip to town. I commonly hear of elderly people having to leave at the crack of dawn to get to their appointments, or having to go into town 3 or 4 times a week, when each round trip is 2 to 4 hours and does a lot of damage to their cars. Some private specialists in the city manage to streamline their appointments like this, so perhaps we can learn from them, and it shouldn't cost any additional cost to the healthcare department, just a rearrangement and a streamlining of things. I would also propose a change to the GP Medicare billing to allow an appointment which is long enough to take a full history and physical examination for rural patients. To travel 2 hours or more for a 15-minute appointment which yields no result is such a deterrent to even trying to make contact with a doctor. I would say perhaps people don't understand our culture, but when rural people, especially farmers, seek help, they have already tried everything they can and put up with terrible symptoms. You may have just one chance to get it right, or lose them as patients until it really is too late to diagnose their problem. Thank you.
Well, once again, thank you, Mrs. Bird, for detailed opening statement. And once again, a further example of coming with ideas and thoughts genuinely to address matters that are identified in our local community around the matters that this inquiry is considering. Now, we have half an hour for questions, and what I'm going to do is, because I came under some reasonable criticism yesterday of going over time a little bit with the sessions, is we'll do it quite tightly, 10 minutes each. It was constructive criticism, yes, indeed, I accept that point, indeed, it was constructive. But to obviate the problem today, we'll just keep it 10 minutes tight, and we'll just have the bell, just, the only reason is, please don't actually ask a question after the bell and say, can I have that question?
Oh, it's Walt's fault.
So it's not dobbing in any particular member. Bacon, I self-identify, not a problem with that, but I won't identify them. So 10 minutes each, so we'll start with the Honourable Walt Secular, who this wasn't referred to at all. So
Thank you, Mr. Chair. And in line with the declaration that Mr. Khan made yesterday when we were in Canada, I'd just like to disclose to the committee that I've worked with Mr. Thompson about 2006 to about 2008 in Canberra. So I just thought it was appropriate in line with yesterday's declaration.
Thank you.
But I would make the same declaration.
That's respected. Thank you for that.
Okay. On that note, Mr. Thompson, so Korakai has been without a doctor since 2017 in the town of 2008.
No, longer than that.
Longer than that.
Yeah, the last VMO at the hospital stayed on for about a year and then went into Lismore, and we were left without a doctor then in 2012. After some effort, we managed to encourage a practice in Casino to establish an outreach clinic in Coracai. So we had a doctor there for 1 or 2 days a week, but it was really insufficient to build up a client base, and after about 6 months they withdrew back to Casino. So I would say since the end of 2012 or 2013 we've been without a GP.
So what are the residents doing there since 2013? So almost 8, 9 years. So what are local residents doing to get health care?
We go to doctors in Evans Head,
Yep.
or Lismore or Casino, or sometimes Ballina and the Gold Coast.
But is it frustrating to see a Health One facility there constructed, built, and not have? Because I've heard it said in the past that having a doctor is like having a heart in the center of one of those facilities.
It is, and it is frustrating. We're very grateful for the Health One. It's a terrific facility. It should be very attractive infrastructure-wise for a GP, but it hasn't been enough to attract one.
So are people neglecting health problems or reluctant to pursue concerns about their health because of a lack of doctor in the community?
I would say so. Yeah, we have, I think, 12% Aboriginal population in Coracai. Many of those don't have their own transport. So the effort of finding transport to get to a doctor, and often you have to wait at least a week to get an appointment with a doctor, that effort is simply too much. So I'm sure many of them leave their health concerns unattended because of the difficulty of seeing a doctor.
Mrs. Grundy, do you find the similar situation in your community?
Yes.
So what do local residents do there when now I understand you're quite pleased that their doctor comes 4 days a week, but
Yes.
what happens on the other days, on the other 3 days a week?
We suck it up. No,
How large is your community?
it's about 3,000
3,000 people.
in the whole district, yes.
You laughed when you said that we suck it up.
Yeah, no, we do use our ambulance service, and we get deposited in either Casino or Lismore if there's a real problem.
Sorry, what do you mean use the ambulance service?
Well, the ambulance service is called if there is a problem.
Yeah.
But if you're just going for a routine appointment or something, there's a wait, at least 2 weeks to get into the local doctor. I don't know what wait times are like now in Lismore or Casino. I think it would be similar.
Sorry, back to your doctor that's he's there for, is it a male?
Pardon?
Is the doctor a man?
Yes.
Yeah, okay. So what is the wait to get to see the doctor in your community?
About 2 weeks.
2 weeks. Now, if you actually had to make your own way to a hospital or to a medical facility outside your community, how long would a trip like that take?
From 1.5 hours to 3 or 4 hours, depending on where you reside in the area. On a rural property or something, it could take quite a while. Our roads are quite rough. A lot of people don't like to travel at night because of, straying cattle, kangaroos, wallabies, all sorts of things on the road.
Now, if you actually take an ambulance what's the closest major hospital? Is it Lismore Bay? Is it Lismore?
Casino would probably be the first, but they usually take us to Lismore.
Why do they take you to Lismore rather than Casino?
It's the only 24-hour hospital service.
Now, what would a resident do in your community if they're discharged from Lismore Hospital? How would they get home?
That's one of our huge problems. Like Sharon Bird has just told you, and it's a big problem. We get shuffled out, and there's sort of the transit area. You have to wait outside because they don't have no room in the transit area, no room in the hospital for you. So you're outside. You have to call somebody to come and get you, or some people just don't have somebody else to come and get them.
So what do they do?
To be honest, I don't know. I suppose somebody will eventually come and get them.
Eventually.
Yes. I mean, this used to happen to my son-in-law. We used to, my daughter actually used to work out that she had to follow the ambulance. But he'd get put out about 2 or 3 o'clock in the morning, and either one of us had to run in and get him, or like I said, she went in now. She used to follow the ambulance and go in and pick him up after some time. Or
But Lismore Hospital is discharging patients
yes, they
in the
discharge.
middle of the night.
Yes. Yes, and I concur with everything Sharon Bird has said. Our people are left there. We've got no means of getting back. There's no public transport. The ambulance has gone back to Benalba or wherever to another case. There's no what do you call them now? They're inter-hospital transfer services
Right.
between Lismore and Benalbo. There's just nothing. You've really got to rely on family, friends, neighbours, whoever's coming to town to pick you up. And you're really, if you've gone into town without your wallet, or the ambulance has picked you up in a comatose state or whatever, you really are in a lot of trouble.
Thank you. Could I ask a question to, Mrs. Bird on the telephone?
Yes, you can.
Can you hear me, Mrs. Bird?
Barely.
Okay, I'll come closer if you don't mind.
That's great.
Now, do you find yourself as the pharmacist in the community providing de facto health care to the community?
Absolutely, and that's a free service because we don't have any funding to cover my time with that. The demand is much greater when the doctor isn't here, of course.
Do you find that it's a position that you assume a lot of responsibility and a lot of pressure that I'm sure you take it unwillingly, but it's a situation you find yourself in under a lot of pressure and an obligation to the community?
Yes, but it is something that we are trained to do as pharmacists, but there is still a line that we can't cross. There is a new initiative by the federal government called continued dispensing. When somebody runs out of prescriptions, if they can't see a doctor in time, we're allowed to do a repeat of their chronic medication.
Do you find that you're called upon, because of the remoteness and a lack of health care in your area and the lack of a doctor, that you're called upon to use this service or this mechanism much more often?
Oh, yes, definitely, quite frequently. But it has been a real blessing. We're allowed to do that once a year for each medication. I used it to help some people. No, I didn't. It was before. It came in, I needed it during the bushfires. I remember a couple that had lost everything, but I rang their doctor and I said, do you mind if I just give them one of everything? And he backed me up with some prescriptions later on. But if that happened again, it would cover us in that sort of emergency situation too. So even though that's a federal program, I would encourage you to talk to your colleagues to make sure that that continues once the COVID threat, don't let them stop that.
Can I ask you one last question? So what do you do when you have someone appear in your pharmacy with a major health problem, with no doctor on duty, no hospital? What do you do in those major situations?
Okay, I had a lady have what looked like a stroke, so we just gave supportive care and called an ambulance for her. And the ambulance took about 45 minutes to get there, so it was a really long time. Sometimes you'll refer people and they just look at me and say, oh, I'm not going to call an ambulance because they'll send me into Lismore and then I'll get stuck there. So sometimes, or I might say, look, this is really serious, you need to see somebody, and they'd just look at me sadly and say, it's just too hard.
Now, the lady who had the stroke, were you able to provide the assistance for her and get her to hospital?
Yes, we were able to give her some aspirin. We were able to just be with her and encourage her and just hold her head up and all those sorts of things. We would have physically taken her up around the corner to the hospital, but she couldn't walk, so we needed an ambulance to transport her, so we just waited until the ambulance got there.
Thank you, Mrs. Bird. That's the end of my time. Thank you.
Thank you.
Thank you. So we'll move on to crossbeds. So, Maureen Hurst, and then I'll go to him.
Thank you, Chair. Mr. Thompson, we've just been hearing about from Mrs. Grundy and others about ambulance services, but in your submission you said that there is no ambulance service in Coraki. Is that correct?
There's no ambulance in Coraki, but we do, of course, have access to the ambulance
But
service.
how long would that take? If it's...
Well, it takes 30 minutes for an ambulance to get to Coraki from either Lismore, Casino or Evans Head, which are the nearest stations. And then, of course, it'll take another 30 minutes to get to either Casino Rural Hospital or to Lismore Base, which is the normal destination.
And what does that delay mean in practical sense?
Well, I can tell you from personal experience, my wife suffered a stroke in 2012 at home, and I called the ambulance. Now, the ambulance took 25 minutes to get there, which I thought was pretty good. But by the time the paramedics consulted with the hospital to make a diagnosis of what ailed my wife, it took another 40 minutes to get her into Lismore Base. So well over more than an hour had passed since the onset of the stroke, and the window of opportunity to administer thrombolysis to try and break the clot in her brain was closing when we got to the hospital. And there was no neurologist there, and there was no stroke unit. So the doctor on duty consulted by phone with John Hunter Hospital, and we spent probably an hour or two toing and froing about whether thrombolysis was appropriate in her case. And the decision was eventually reached that it was. So she was injected, but regrettably it was not successful, and my wife suffered a couple of hemorrhagic strokes as a result of the thrombolysis. And then, because she couldn't be put on to blood thinners because of the hemorrhagic strokes, she suffered another couple of ischemic strokes as a result of her underlying atrial fibrillation. And she ended up in quite a mess, and she's never walked since. So
Do you think
that the ambulance service could have saved vital time in her case.
And do you think also having access to specialists in the stroke area would have helped as well?
Most definitely, most definitely. I know a stroke unit was subsequently established at Lismore Base, which was a great improvement, and there's now a tele-stroke virtual health service, which I believe is achieving quite a lot in rural areas.
Another thing you said, I think when you were talking to my colleague from the Labor Party, you said that the new One Health facility was a good facility, but it wasn't enough on its own to actually attract a GP into the area. What is needed to attract a GP in the area? Is it just extra financial benefits, or are there other things that are needed as well?
I think it's a combination of factors that affect lots of rural communities. First of all, perhaps it's the lack of financial reward. There'd be fewer services, I think, than metropolitan doctors would get. That's one factor. The client base perhaps is not big enough. Another factor is the lack of professional support for single rural GPs. Now that's gradually being overcome by telehealth, because the GP can consult professionals elsewhere, specialists elsewhere for advice and mentoring, but that's another factor. Another factor is the lack of employment opportunities, relative lack of employment opportunities for the spouses, perhaps lack of education opportunities for children, These are all factors that influence a GP when they're considering whether to go to a rural community.
We've talked a lot about telehealth, and while I think there's been an agreement that it can be an essential service, there are a lot of concerns in different places that there's an over-reliance on that because of the difficulties of getting GPs and specialists into areas. Are you, or this is probably for anybody, is anyone nervous that there'll be an over-reliance on this system in their local areas?
I think, yes, I think there's a fear in communities that telehealth will be a substitute for face-to-face services, and we don't want that. As an addition to those services or for filling gaps when those gaps are unavoidable, yes, it has great advantages. But in Corico, for example, 1/3 of households, this is going back to the 2016 census, didn't have internet. So, and they're probably the people that most need access to the health services. So telehealth in their case is not much use.
Can I just jump in with a question and won't cut into Kate's time? Just, if you don't mind, Ms Fletcher, just to you. In regard to the provision of palliative care services, would you like to comment on those?
Palliative care.
Yeah, palliative. So obviously you're dealing specifically with the cancer through your work, but obviously at the end of life, the need for people to transition into palliative care to deal with the lead up to their death. Are you able to make any comment about your observation with respect to what's available to help people at the very end stage of life?
I'm not prepared on that answer. What I do know is that Ballina has a palliative care unit, it works well for it. It's something that has improved in the last bit, but there's always a gap. I've heard some good reports. I think it's a changing space. What I'm more aware of the trauma that people have when they first hear of it and their mental health of their diagnosis.
Right.
And palliative is further down.
Yes.
So it's a long journey because there's like a diagnosis, there's your treatment, and then it's living life.
Yeah.
And
then the final. Yeah.
And then, so one of the great concerns is also when people get secondaries come back, and that's another great trauma. I mean, palliative to me is a separate issue.
No, that's okay.
But
But it's part of what is a series of stages people will go through to the end.
it's a long journey.
Okay. And then back to...
Now, I'm going to be restrained this time.
Good.
Thank you, Chair. Just listening to all of your evidences, hearing about the lack of GPs, the lack of ambulance services, but we're also hearing about more and more people moving to the northern rivers, particularly from Sydney. A lot of these people, when they do fall ill or get injured, are in for a bit of a shock, aren't they? In terms of the lack of health services available. Mr. Thompson?
They are, but most of them tend to settle in the coastal areas where there are more services. You know, Evans Head, for example, is well served by doctors. It's only got a population of 3,000.
I feel like every second person I talk to talks about moving into the hinterland, to be honest, and including around places like this.
People.
Order.
So the situation here has gotten surely worse. It sounds like it's gotten a lot worse over the past 5 or 10 years. Is that your view as well, Mrs. Grundy?
Yes. Our services have been getting less. Especially our allied health professionals aren't being replaced and are not coming in regularly.
I'm thinking with the particular situation of the Lismore Base Hospital at night and having people going to the emergency department sick and then being booted out at a certain time in the middle of the night with no transport available. Do you think that's a result of KPIs set by the government to ensure that people are discharged within 4 hours? Have you heard anything in relation to that? Mrs. Bird, I might go to you first.
She may not have heard that, Kate.
Sorry. Oh.
She may not have heard that.
Okay, I'll go to Mr. Thompson then, and then I'll repeat it.
Look, I don't know the answer to that question, but I would guess it's due to the demand for beds. You know, there's a huge demand on beds in the hospital.
Are you aware
so
that
when
the
people
government-
are ready for release, I would imagine the hospital takes the opportunity to release them and free up a bed for a more urgent case.
You are aware that there is a KPI. There's a KPI set by the government, which is a 4-hour discharge from people going into emergency departments.
Yes.
I just wondered whether people locally were talking about that. No.
I know that benchmark is there. I can't remember the extent to which the Northern New South Wales LHD meets it, but I think they go close.
It sounds like it if they're booting people out in the middle of the night. Should I ask Mrs. Bird that question? Mrs. Bird, it's Kate Fairman here, one of the committee members. I've just got a question in relation to the people who are being left on the side of the road, it seems, after being ejected from the Lismore Base Hospital in the middle of the night. And some of the witnesses and submissions have mentioned that this is happening more than once, as you have said. Do you know whether, or do you think this is in any way due to the fact that there is a KPI of that has been set in recent years for there to be a 4-hour, for people to be discharged, if possible, within 4 hours after upon entering an emergency department? Are you aware of that KPI?
No, I wasn't, but it certainly makes sense because we couldn't understand, as a community, and I've been part of the Chamber of Commerce Committee in town here as well, and it was raised as an issue, some time ago in that committee as well. So now I understand a bit more why that would happen. But often if it's an emergency and it's the middle of the night, I have a friend who was a single man, hadn't been in Benalbo long, had a pulmonary embolism, rang the ambulance, and I think that he managed to stagger outside. He'd left his wallet behind on the floor. He was wearing his pyjamas. He dropped his mobile phone on the way. He dropped the house keys outside by the car. And the ambulance got there, picked him up, put him in the ambulance and took him off to the hospital. And he called me later that day from his hospital bed. And luckily he had us as friends. He was renting my house at the time. So I went there, collected the keys, collected the mobile phone, put his wallet somewhere safe, collected some clothes, and we were able to drop them off to him. But, that's just another example, happens often.
Can I just be clear?
Other people, you say. Sorry.
Just to clarify, he was collected after he was discharged from the hospital, ultimately collected by the ambulance to go back to the hospital.
No.
that's what
Well,
I
he
thought.
had us, so he wasn't completely bereft, like some people might be. But he could potentially have been left in that situation. And other people I've tried to encourage to call an ambulance just look at me and go, no, I might just be stuck there and I won't have a way to get home. They would prefer to drive themselves in to the hospital so they've got their car there for transport to get home, but that's not always wise either.
Not always, thanks.
Thank you very much for all appearing today. And I just wanted to touch on the Corokai Hospital to start with, Mr. Thompson, if you wouldn't mind. Are you able to talk about the hospital before it suffered the storm damage and the like? What services were provided at the hospital, and was it did it have an ED that was 24 hours, or was it partly staffed, during business hours and then on call afterwards? Do you know those details?
It was a fully staffed small rural hospital. It did have an ED capacity, and there was 24-hour on-call ED attention there. There was only one VMO, I think, at that stage, so that service would have been pretty thin.
Yeah.
And most of the beds towards the end of the hospital's life would have been used more for rehab than acute care.
And was the doctor that provided the, say, on-call service there also a GP in town?
Yes.
Yeah, so... And how many GPs did you have in town back when the hospital was...
Well, back in 1996, there were 3. Yep.
Okay.
And I think when the hospital was closed in 2011, there were, probably, there was the resident GP in Corokai who was also the VMO.
Mm-hmm.
There may have been one other doctor on call as well.
Okay. So they did share the on-call, and it wasn't a one doctor doing the on-call the whole time and the other two GPs just being GPs in town. It was a...
Well, that was
service.
way back. That was when I first visited
I know, I'm just trying to
before I
establish
became a
the
resident.
baseline of what was in Corokai before. So,
in its heyday, yes,
Yes.
It was a fully staffed hospital running acute care and all sorts of care.
Yes.
Yeah.
But I take it, Mr Thompson, what you're describing is what's occurred really throughout regional Australia over the last 30 or 40 years, and that's been the gradual drawdown of GPs that are available to small communities.
Yes, definitely.
Do you think, in regards to that, this situation has been exacerbated by, for instance, the cap that was placed on increases in Medicare rebates for some years by, I think, governments of both persuasions, that's made general practice less economically viable?
Yes, but those caps probably apply equally to rural and metropolitan practitioners.
That's true, but you've also pointed out that really the patient base for general practice in small communities in particular is much smaller than what you can get in a large city practice.
That's true. I mean, the government's recent decision to increase Medicare rebates for rural hospitals should help.
Yeah.
Whether it solves the problem or not remains to be seen.
Would a more available loading for Medicare rebates in rural and regional, particularly small towns, also potentially help in attracting back, or help in attracting general practice back into these small towns?
I'm sure that would help. Yeah.
Trevor, you're trying to argue this community has been without a doctor since
Look, Walt,
2013.
come on, Walt. Just behave yourself for a change.
Not for a change. Let's just continue the line of questioning. So Trevor's got the call.
Thank you. Look, I think the answer is, and you've identified that what we've now received into this inquiry are submissions from across the state, and I'm sure if we're in the Senate across Australia, that shows there's been a gradual drawdown, a gradual loss of that general practice skill base.
Yes.
And really there needs to be some substantive response to that basic criteria, or that basic problem that exists in our community.
Absolutely.
Have you got any other suggestions as to what may, and obviously, for instance, you've seen some of these submissions like Dr. Holliday's yesterday that we got in Manning. You got any suggestions as to what you think might help attract back those, and I direct this to the three of you, attract back general practice into these towns?
Well, there are a range of initiatives that have been taken by different local councils all across the state to assist with rental of premises, provision of a house for the GP, assistance with transport. But even those initiatives don't seem to have been able to completely address the problem. And I would also argue that it's not a responsibility of local councils to be providing ongoing funding for GPs.
Let me just say, Mr Thompson, you've got me on board on that. There is a division of responsibility in these matters.
I think Mrs. Bird might not respond.
Oh,
to that
sorry,
question.
yes.
Oh, yes,
I forgot you
please.
were there.
I think even you've really got to look to the whole family, and one of the biggest cultural changes in the last 50 years has been women entering the workforce en masse, and so you're really looking for jobs for not only your GP but also his wife, who's most likely a professional, and there just may not be anything available for her. And also, if that's the case and you're looking at a family man, then he's looking at educational opportunities for his children, which may or may not be appropriate in a really small town. So unless you can make their families happy, they're not going to be likely to come and live and work in a rural area. Having said that, why wouldn't you be able to get somebody in Corokai? It's lovely. It's quite close to the coast. It's close to bigger centres. You know, if we can't find somebody for places like Benalba and Corokai, you've got no chance of finding somebody to go and work in Gunnedah.
Well, as I live near Gunnedah, I think it's been on Gunnedah, actually.
My son's just spent 5 years in Gunnedah.
All right, there we go. Mrs. Bernstein, I got you there. In terms of the restrictions in terms of what you do at your pharmacy, are there any changes that either the state or Commonwealth governments could make that would broaden what I could call the allied health services that you are capable of providing to your community that you're currently restricted from doing?
Yes, definitely. There's no reason at all why pharmacists couldn't be given a Medicare billing number or capability for consultations on minor health conditions.
Yeah.
Because sometimes the best management is not necessarily a product, it's more advice. So that would help greatly. And I think there are a number of areas we could help in. One that's been suggested is helping in the case of urinary tract infections, because if a person gets prompt antibiotic treatment there, they can avoid a kidney infection and subsequent hospitalisation. Another one that would be very helpful, I think, would be in cases of vertigo or gastrobugs and things like that. If we had some limited prescribing capabilities there, it might help. So the sort of the roles that like a nurse practitioner who's got a right to prescribe, that might be very helpful. I have the pharmacy open from 9 till 5 each day. We're very busy in the mornings, but it would be possible to change the practice so that you were doing more consultation-based work in the afternoons. So that would be a way that you've got a trained person who could fill in some of the gaps when the need arose.
Mrs. Bird, it was indeed the nurse practitioner concept that interested me in terms of what pharmacists do. Would there be a need for some form of additional training to be available to you to fulfil that role?
A lot of that would have been covered already at university, especially in the modern courses as well. So I would say it would be fairly minimal training, maybe an examination to make sure that that person's clinical skills were up to scratch. But just to have the opportunity to do some minimal prescribing and maybe being able to do some minimal, but increased examinations of the patient or history taking, that kind of thing, would help a lot, I think.
Well, my time has expired, Mrs. Bird, but I'm most appreciative of your comments, and I thank the other witnesses as well. And I'm sorry I've taken my friend's time.
No, you're not.
Thank you. Thank you very much.
I lied.
All good banter amongst members here. We're all good.
Sometimes.
That draws that session in just a few seconds to a conclusion. But on behalf of the committee, can I thank you all present, and you, Mrs. Bird.
Thank you.
Over the telephone for the frankness and the clarity in which you've been able to answer some specific questions and particularly inject some very interesting and valuable ideas to supplement what was said in both your submissions and opening statements. So thank you all very much.
Thank you.
Thank you.
Okay, well, we'll move now to the next set of witnesses. So ask them to come forward.
Thank you.
Thanks, Mrs. Bird. the next session underway. Next panel of witnesses. So first of all, thank you on behalf of the committee for making yourself available to come along today to provide the opportunity to supplement the content of what were some very good submissions. So thank you very much for that. We'll get through the formality of having each witness affirmed or sworn in to give their evidence. So moving from my left across to my right, I'll get each witness to state their name, their position title. Now, if you're appearing here as a private citizen, that is your position title. If you're representing an organisation, that would be the organisation. But I understand all of you are appearing in your capacity as private citizens. And then swear either an oath or an affirmation, whichever you prefer, that the words of both should be before you. So we'll start with Mr. Hutton Gillard. Is that how?
Andre, Hutton Gillard, yes.
Thank you very much.
Right.
Thank you.
So I start with the affirmation.
Certainly, please.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Dr. Ruber.
Thank you.
Okay, my affirmations. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Doctor. Mr. Hall.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Mr. Robinson.
Christine Mary Robertson, private citizen. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Before we go any further, can I just take the liberty of welcoming Christine, who many of you would know, and if you don't, I want to acknowledge this, had a distinguished period of service in the Legislative Council, a member of the Labor Party, and someone who, over the years that I spent with her in the Council, which were a number, if there's one area that would have to be identified as a policy area of not just interest but declared advocacy over, it's the matter of health and health outside the margin metropolitan areas. And Christine was, I sort of might put the words this way, quite a warrior in her own way inside the Labor Party, and it's being a bit political, but I want to say that, but also in the House itself, about drawing the attention to the needs of the citizens of New South Wales outside the major metropolitan areas, in drawing attention to whoever the minister of the day was. In those days it was a Labor government ministers, of the need to give proper attention to the needs of people outside those popular areas. So I just want to acknowledge that. And,
thank you, Mr. Chair.
You. So I invite each one of you to make an opening statement. Now, if we could keep them reasonably concise to enable a maximum time of questioning, so a few minutes, 3-4 minutes, would be good. So if we start from my left, an opening statement, and that'd be great.
Thank you. So my name is Andre Hutton Gillard, and my submission was number 206. I want to talk about my own experience and draw your attention to the high cost to the state and individuals associated with waiting times, and submit that underfunding rural and regional health is an illusory comparative economic advantage, because you'll understand why when I want to inform the inquiry about additional troubling information received since lodging my submission. I'd also want to talk about the unrealistic workload of nurses and doctors in hospitals and the security issues that they face. And since I have been invited to witness, I have read other submissions, and a couple of them reminded me of something I experienced unrelated to my own submission. And if the chair will allow me, I would like to touch on this as well.
Please.
Thank you. That is my introduction.
Thank you very much. And thank you. Forgive me, I should have actually declared at the start, with respect to all your submissions, they've been received and processed by the Secretariat and stand as submissions to the inquiry. So quite correct, yours, Sarah's submission 2006. Doctor, yours is submission 218. So did I say 2000? Yeah, 206 I should say. 218, Doctor. Mr Hoare, 426. And Mr Robertson, there's two, as you'll be aware, 432 and 432A. So they've all been processed and uploaded on the inquiry's webpage. So thank you. Doctor, would you like to make an opening submission?
Okay, thank you. So, my name is Dr. Florian Weber. I'm by training a veterinarian with specialist skills and postgraduate qualifications in infectious animal diseases. I work for a local veterinary contract research organization that conducts contract research for the animal health industry and therefore requires quite specialist personnel with specialized skills. I moved from metropolitan Melbourne to the Northern Rivers region in early 2019 to commence this position, but unfortunately became unwell with a neurological condition within the first 6 months of my arrival. My neurological condition had an acute onset in August 2019 and resulted in a marked weakness of my right hand and the inability to fully extend my fingers, as well as chronic pain in my right arm and shoulder. Not only that this condition has seriously impacted on my ability to work and my quality of life overall, but I also had to experience significant lack of certain medical professionals with the required expertise to accurately diagnose and treat my condition. And basically the end of the story was that I had to travel to the Gold Coast to find specialist neurologists and neurosurgeons, and this has resulted in significant expense for travel as well as time off work. So therefore I'm grateful to be given the opportunity today to share my story with the committee and hope that this will increase the awareness of the medical needs of the Northern Rivers community and people residing in rural and regional New South Wales altogether. Now I guess the key message I want to communicate today is that the lack of specialist medical professionals in rural and regional New South Wales means that patients residing in these areas are disadvantaged to those that live in major metropolitan cities. Also, often patients have to travel long distances.
Sorry to interrupt. Would you mind if we because that was captured quite a nice opening statement you just given, getting into the specifics of your particular, do you mind if we just get to the other opening statements and we'll come back to you?
Of course.
So, sorry to cut you off, but we'll certainly return once we get through the opening. So, Mr Hoare, do you have an opening statement?
I might ramble on a bit before I get to my submission, but...
just if you concentrate on what you'd like to draw to our attention, and I'm sure in the questioning that comes from the members, it'll draw out the specifics you want. So.
Not specifics, just a few other things. This affirmation I don't mind taking, but on your first page here of being a witness, you're talking about opinions and perspectives. And that's what I bring. I'm not to paraphrase previous PM, a suppository of facts and figures, but I've got opinions and perspectives.
We are more than happy to hear your opinions and thoughts.
And another thing, there's 708 submissions, 273 had their names suppressed, 87 were confidential. That adds up to 50.8% of all the submissions, that's over half. And I suggest that that's due to fear, because a lot of the submissions were from staff, nurses and doctors, and some mention repercussions and backlash from health departments or community. The other thing I'll briefly touch on, because New South Wales Farmers Federation has brought it up nicely, is about dental health. There's very little been talked about that, but they suggest it should be in Medicare and bulk billed. There's a lot of expense in that. And the other little point is our choice is to live in the rural area for health, and it might be a problem sometimes when injury or sickness happens, but we feel advantaged and privileged to live in the bush. We live 2 hours away from here, half an hour from Benalbo, which is our local chemist and hospital, and sometimes floods and other things get in the way of being able to get anywhere. But we're used to travelling anyway.
Sorry, so where do you specifically live?
Where?
Where do you specifically live?
It's called Lower Duck Creek.
Lower Duck Creek.
Yeah.
Sounds like a beautiful place.
That's a great place.
Yeah.
On the eastern fall of the Great Dividing Range.
Okay.
Our place was completely burnt out by a huge bushfire in late 2019, which makes things a little bit different.
Yeah, no doubt.
In my submission, one of the main things that happened to me personally was presenting at the ED at Benalbo to get stitched up. And that occasion I've mentioned on the submission, there were 3 nurses in Benalbo and none of them could stitch me up. So they contacted Urbanville, which had a on-call doctor, and Urbanville suggested they send me to Casino, but the nurses told them, or told me to just present at the ED and they probably wouldn't turn me away. So that was one experience. That was a half an hour drive to Benalbo, another half an hour drive to Urbanville. And in between I had to knock up the local petrol station because I was low on fuel, so it was after hours, of course. Yeah. And the other thing, probably the main thing, was talking about medications. I've got a long-term, stable, finite condition that doesn't change. No history of abusing the medications I need to take. This is 25 years ago I had a brain tumour, pituitary adenoma, and I take thyroxine, cortisone and testosterone and a couple of other things to sort that out. So what I suggest there is, well, this might be a detail, but that there's established a hotline that someone can identify me on the other end. I say, I need this, I need that. They post the medications to me. We pay in the normal way you'd pay for any transaction on the phone. And the next day or so, I've got some medication. Sharon Bird has been very helpful with that. She's our local pharmacy.
Yeah, we've had one.
And I've got nothing against Mark, the doctor there. He's a great doctor, but he's only there 4 days a week. And there can be considerable waiting times. I've got other things, but...
No, that's very nice. There's a lot of detailed information there from a personal point of view. And can I say thank you for being so honest. It's not easy to come and sort of lay out, dare I say, parts of your life so openly as you've done in a public fashion, but it does enable us then to look at some fine detail around some of those issues you've raised. So we thank you for that. Ms Robinson.
Thank you, Mr Chair. I'll find my... Oh no, you're not going to have a voice. I recognise the traditional owners of this land and their elders past and present. No, you can't have a voice.
Have a sit.
I'll try that.
Okay.
And emerging. Thank you for inviting me to participate in this inquiry. And as already been stated, I personally know some of the committee members. I came here not to speak. I do beg your pardon. Oh, there you go. My main issue relates to planning processes in rural healthcare. I'm concerned there's been no update of the hospital role delineation in this local health district since 2016. The role delineation documents, obviously from the health submission that's on the end of this day, is an incredibly important component of rural health, and if it's not taken any notice of, I really have come not to speak. Role delineation is the way you tell at what level a hospital can deliver service and when people should be moved onto a higher level facility, a function which used to belong to the area planning departments, using the Health Ministry specialist-led role delineation guidelines. The guidelines are constantly updated despite the fact the submission at the end of this day says it was last done in 2016. When you go to the net you can see there's new dates on the bottom of the role delineation document, so it's constantly updated. And it says when people should be moved on to a high level facility. Oh, I said all that. The guidelines are constant. The data collection is absorbed by patient satisfaction surveys, it would appear to me, occasions of service and waiting times, and used by political tools by both sides of Parliament. Always have been not useful data collection tools for health outcomes. There is a local health district strategic plan which mirrors the board's contract with the ministry. There's no current service plan that I can find for this local health district. Operational staff are responsible for maintaining budgets, implementing the central statewide silos, managing equipment failures, managing the community advisory groups, managing the constant staff shortages currently compounded by our accommodation crisis. Like everywhere on the eastern seaboard, rents and housing have gone through the roof, and it would appear from our experience in Maclean organising major hospital changes. The mothballing of an acute ward in Maclean was stopped by community outcry. Not good enough. That's not good enough. Not good enough the community outcry stopped it, and not good enough it was to be mothballed without proper planning processes. It appears that health planning is now totally covered by contractual consultants. The current process at Grafton and Maclean does seem to be comprehensive and should result in clinical services planned for the future of health services for the Clarence. That's the low bit of this local health district, which is and the Clarence is a perfect example of an underfunded rural health service. Nothing like an election to get a promise. Too bad. We got the planning because there was an election on. Health services need to be right and happen at the right place at the right time. We need assessment, referral and transport, and the ability to look after the people who fit into our service delineation. We don't need brain surgery, cardiac surgery, inpatient mental health, midwifery and paediatrics in every town. We need the funds, staff and resources to deliver what we actually need. And the rest in my submission. Thank you.
Thank you very much, Mrs. Robertson, and as usual, very pointed and very clear.
I'm so sorry I'm out of practice with my voice. I don't use it now.
Actually, I could hear the German speech. I could hear the German speech ringing in my ears from years gone by. So, but thank you so much. We'll open it up now. Questioning. Now we're going to have effectively about 12 minutes thereabouts from each group. So, Honourable Secretary.
Thank you, Mr. Chair. Mr. Gerard, can you tell me a bit about the difficulties that you faced? So, where do you currently reside?
I live in Lismore.
You live in Lismore. So, you actually had to seek services in Brisbane and the Gold Coast because of...
Yes, I was diagnosed with atrial fibrillation in 2006.
I'm sorry, can you explain that in simple terms? What does that mean?
It's the heart that doesn't beat properly.
Yeah, thank you very much.
And I had to wait 14 months to see for my first appointment with a cardiologist.
14 months?
14 months.
In New South Wales?
In Lismore.
In Lismore?
Yeah.
And then what happened at the end of the 14 months?
I met the cardiologist. I had a stress test, ultrasound, blood test, whatever, and he put me on some medication, and that worked well for a number of years, in fact for a long time, but I had a heart attack in 2016, and the medication I was on, he had to withdraw because it was not appropriate after my heart attack. He put me on another medication, which I was allergic to, and so he recommended that I have an ablation, which is a procedure where they burn a part of the heart that causes a fibrillation. And he recommended me to the Princess Alexandra Hospital in Brisbane. I had to wait a long time, I can't remember how long, but very long time, more than a year, to see the cardiologist at Princess Alexandra. There we discussed the case and everything, and he thought that I could have an ablation, but he thought that I could go on a drug called amiodarone, and that would keep my heart in. So I went on amiodarone, but after a year, it affected my thyroid, so they had to take away, and they didn't have any more medication to regulate my heart anymore because I was allergic, or the drugs were caused side effects.
So in the meantime, so you're driving from from Lismore to the Gold Coast to Brisbane.
Well, well, all right. What happened is that, let me try to get the sequence right. After a year, they had to take me off amiodarone, so my cardiologist decided that my cardiologist in Lismore decided that he would recommend the ablation again. And he said, my staff will advise the hospital and so forth. And after 6 months, I had another appointment with him, and I asked him about where did I stand in the line, and he said, oh, well, he doesn't know. He'd asked his staff. The next day, the staff called me, and they said they called the hospital, and there was a staff up, and I was not on the waiting list. So they put me on the waiting list, and I was at the end of the queue. And then I got a couple of years, what was last year, I think, I got a call from, or 2 years ago, I got a call from the Princess Alexandra Hospital, and they advised me that they were transferring my case to the Gold Coast University Hospital because of COVID, and I couldn't travel to Brisbane. So the Gold Coast Hospital let me know that they received all the papers and so forth, and that I was in line, in the queue and so forth.
Why did your cardiologist explain why you couldn't be treated in Lismore? Is it a rare?
Well, they don't do this procedure here, and this is something that I want to question as well, because LBH has a state-of-the-art operating theatre suite and intensive care cardiac unit, but they can't perform an ablation. It seems like an aberration to me. But anyway, that's how it is.
That's why my questions are actually getting to that point, so that there is, I understand, state-of-the-art facilities here.
Yes.
But they're not. And they're not being used or maximized. So how did that make you feel when you discovered that you were traveling to Brisbane, to the Gold Coast?
Well, it's very inconvenient, but I'm very lucky because I have mobile.
Yeah.
I have support from my wife and my children. But I'm thinking, if I was alone and if I had a pet or something like this, it would cause a lot of stress in my life.
And what did you do during COVID? And during COVID, when the border closed, what happened? Were you able to get through?
No. So what happened is I had to wait until January of this year before I could see the cardiologist from the Gold Coast Hospital. And that is only because having no drug to care for my fibrillation, I was hospitalized 5 times for cardioversion.
Here in Lismore?
In Lismore.
In Lismore.
Cardioversion with TOE, which is a transesophageal electrocardiogram. And this is done under anesthesia, and it costs a lot of money, obviously. So I've been hospitalized 8 times in Lismore. And I'm going to say, I'm going to read from this because not counting tests carried out when I was hospitalized, I had numerous stress tests, Holter monitor surveillance, an inordinate number of ECGs, X-rays and blood tests, echocardiograms, ultrasounds, electrosounds, nuclear medicine perfusion, sleep apnea tests, CT scans, probably more than 50 GP visits during that 4 or 5 years after my heart attack.
But no procedures here?
No procedures. Just the angiograms. In hospital, I also had 2 angiograms, 5 cardioversions, and transesophagus electrocardiograms. And every time I go to the hospital, they do all the normal blood tests, X-rays, sometimes CT scan and more. You know. So that's an awful lot of cost just for waiting in line, right? And the cost are operating theatre, cardiologists, anaesthetists and assistants, nursing staff in the theatre, in the reception bay, in the recovery bay, and add to this the cost of ancillary services like orderlies, meals, deliveries, cleaners, administration, rehab staff, and so forth. You know, it goes on and on. It's a very expensive thing to be waiting.
Mr. Durrett, thank you. Dr. Robert, is your experiences similar on a lack of specialists at Lismore Base Hospital? Do you have similar experiences to Mr. Gerard?
Yes, I think it's similar. In my case, there was a complete absence of neurologists in Lismore at that time. So when I first saw the GP, the only neurologist he was aware of was up at the Gold Coast. So he referred me to a total of 4 different neurologists at the time to see which one I could see first. And the first appointment happened after 6 to 8 weeks of waiting. So 6 to 8 weeks before I could have my initial consult with the first neurologist, which also then after half an hour talking to her dismissed me, saying that she doesn't have the skill and qualification, or well, she has the qualifications, but not the expert knowledge to diagnose and treat my condition. So to explain a little bit more, I basically woke up one morning and couldn't move my right hand anymore. All of a sudden, it is, so far it has never really conclusively been diagnosed. It's been called idiopathic neuropathy, so idiopathic meaning of unknown cause. And yes, so I basically had to run here to the GP, who said, well, I can only refer you to the Gold Coast. He sends a neurologist there after 6 to 8 weeks, who told me then, I don't know what to do with you. And then it took another 3 to 4 weeks until I was referred to the director of the neurology at the Gold Coast, who then started kind of investigating my case.
So were you able to, did you have to drive yourself from here to the Gold Coast, back and forth yourself?
A total of 15 times or so.
How many times?
15 at least.
And what about working and supporting yourself? How were you able to do that?
Fortunately, my workplace has been very accommodating and kind of adjusted my position to a way that still allows me to work. So rather than being more hands-on on the animals, which is kind of part of what I do, I've been provided with more office duties and have a more managerial role rather than hands-on researcher.
Am I done?
Well, you started on the button, so just...
Okay. Mr. Hoare, can you tell me about your experience? So you live in a place called Lower Duck Creek.
Yep.
So what happened when you went to the MPS, I think it's Bon Elbow SPS, and they said they couldn't stitch you? Were you surprised that you showed up to an emergency department and they couldn't stitch you?
Well, yeah, I'm just trying to think if it was the MPS then or the old hospital.
Okay, well, even a hospital.
One or the other.
Yeah.
So I'd rung them up previously, and I knew there wasn't a doctor there. They said, come in, we'll have a look, it might not need stitching. Yeah. I was pretty sure it did. There's a big gunge in my leg.
Can you tell me, was it a cut in your leg?
Yeah, I was just finishing up for the day and clambering over a trailer, and I slipped off, and I don't know what I hit, but a bit of steel sort of made a bit of had half a runner full of blood, and I thought, oh, that doesn't look too good. You can see all the white bits and that. So I wrapped it up and gave them a ring, and they said, come in, so I did. So that's about half an hour. Yeah, there were 3 nurses there, and they had a look, oh yeah, that needs stitches, but they cleaned it up and wrapped it up and rang up Urbanville, which had, at that stage, a doctor. So, like I said, I knocked up the petrol man and then took off to Urbanville and just had a short wait there and got stitched up.
So how long was it from the accident to getting stitched up?
Oh, well,
And I'll end on that, gentlemen.
Thanks.
hour and a half, 2 hours.
Thank you.
Thank you, Mr. Tom. Your time will not be appreciated by 1 second. The Honourable Emma Hurst, Deputy Chair.
Thank you, Chair. I'd just like to ask Mrs. Christine Robinson, based on the introduction that was given by the Chair and understanding that you've been involved in this space for a long time, what do you think are some of the essential recommendations that should come from this inquiry? What should be some of those top-line things that have been going on for so long that need fixing?
I think one of the biggest issues is that it's very difficult for the community to get a handle on what's happening in health and why. I'm not sure, but there needs to be someone to attack the health department and all health services with a plain English mallet, so that it's explained what health services can happen where and why they happen there. In this area, our tertiary services are mostly offered by Queensland, and some persons go down to Newcastle or Sydney, but mostly by Queensland. So mostly we accept we have to go to Queensland for our tertiary services. There's just no other way around it. We just don't have the numbers of humans or the numbers of disease processes or specialists to have otherwise. So if people could really understand what the role delineation meant, maybe it would be much easier for the services to provide what they need rather than be pushed around by political processes non-stop. So I think that would make a difference. The problem with the lack of GPs is incredibly difficult. Someone put the nail on the head here earlier when they said there's no admitting rights, so we're not going to get a GP. Because the GPs used to come to the country, to the small towns, because they got really rich at it. And they'd come and save up the money for the private school, for the high school, and move on. And so that's gone. That's changed with the smaller hospitals coming. So that's an incredibly important incentive for country VMO GPs that is going away. But I mean, there's 100 things, but they're some of the big ones. And the staff shortages are phenomenal. And it's about too many of our trained persons wanting to become posh and specialists and earn more money, and moving off out of the GP cycles and not recognising the value of community GP to our communities and to themselves. Is that enough?
Yeah, that was great, thank you. Mr. Othenen Gerard, sorry. Are you still waiting for your ablation surgery?
No, so what happened is that my cardiologist in Lismore, after my 5 cardioversions, contacted the Gold Coast Hospital, and I finally was able to meet the surgeon, and that was in mid-January. And the first thing he said is that there is a very long list waiting, and fibrillation is not an emergency. The Queensland government is also starving them of funds, and one of the director of the Gold Coast Hospital suggested that no more patients from New South Wales were processed there. He said that doctors would fight this, but at the moment that was the situation. And
are you worried that that's going to come into place? I mean, what would that mean for?
I don't know if it's come into place. It would be very difficult for the New South Wales government, because they have a whole lot of patients to redirect.
Well, you guys are
to
relying on the
Sydney.
Gold Coast, aren't you?
Yeah.
Yeah.
So then he said, if I can be ready at short notice, if there is a cancellation, he'll be able to maybe slot me in, because he recognizes that my case was a little bit different. And then he read more about my background and so forth, and he said he had brainwave, he called it. The hospital was retained to, he said, if I want to be a guinea pig for testing an invention, American invention, then he could do that test on the 17th of February. And since I'll be in the theater under anesthesia, he'll be able to perform the ablation. The test would last 1 hour. He'd explain to me that it's no big deal, it's safe, and so forth, you know. And on this basis, I accepted. I said, well, yeah, I want to go and do it.
Sorry, can I just interrupt you? Would you have agreed to this sort of alternative test treatment if you hadn't have had to wait for 3 years already?
I don't know, it's an hypothetical, but probably I would have because I was very incapacitated by my condition. Anyway, what happened is that I went on the 17th of February. I had the test and the ablation. I was under anesthetics for 5.5 hours, I think. And now I feel like a new man. I walk 10 kilometers a day. Just, wonderful. And I had to wait all that time for something that could have changed my life and saved the state a lot of money. So this is where I have to question, you know.
That limbo.
Yeah.
Thank you.
Thank you, Chair, and thank you all for coming today and giving your evidence. Sometimes you hear people say that because people move to the regions or to remote New South Wales, that they therefore have to expect health services that aren't as good as Sydney. People choose to move to the regions and therefore that's just, a trade-off, if you like, health services. What do you have to say to that, Mr. Hall? Because you live quite remotely.
Oh, not compared to some of the people I've read about in the submissions.
You're right, yes.
We live a bit away, I'll put it that way, but what was the question again?
So, and this isn't my view, I'm putting at this by any means, but I'm just putting a view that some people say, well, you choose to live in the country, you choose to live in these places, therefore, isn't it to be expected that you won't have fantastic health services? What do you have to say to that?
I suppose we don't expect everything that you'd walk down the street to get in any large city or even a town like Lismore, but basic health things is all I really expect to get there. We were spoilt in a way. Say, 15 years ago, we had a doctor who was a local fellow, Trevor Tini, if I can say his name.
Yes.
Was there forever, and he was on call 7 days a week, 24/7, looked after the hospital, had his own general practice, looked after the aged care facility, which was separate at that stage. And he was just there. His parents lived close. His kids, I think, went to the local high school for a while. So we had that experience of a very good doctor who was there all the time. And that was
That's not too much to ask for, though,
well,
is it? A good doctor
normal.
that you can see in regional New South Wales when you need it. A good doctor when you need it.
Yeah, when we moved there, 30 odd years ago, that was the norm. There was the hospital, there was Trevor, and it was terrific. So I thought, oh, this is all right. Something happened there with me and I had to go quickly to Brisbane, but I didn't expect it to work any other way. And any help after that was done by Trevor locally or visits to Brisbane to see the, what do you call it?
Mrs. Robertson, you're nodding. Can I get your view on that question?
I agree very much with what Mr. Hall's saying in relation to having a stable person who understood how to operate the services in town and look after the people and also refer when required, which is what is required, which is going to the place where he needs the extra care. So, yeah, that's why I was nodding. I was listening to his story.
Dr. Robert? Because you moved from Melbourne.
Yes, I would very much like to comment on your query.
Yes.
So the business I work for requires quite specialized skills and heavily relies on people with such skills, which is not necessarily readily available in regional Australia. I was attracted to take this job because of the good package they offered me, and at the time I accepted that job, I was not ill at that time. So I was kind of at that time unaware of the potential, as you call it, trade-off I might have to accept of moving out here. I was just looking at the change of lifestyle, and it was all appealing to me. But then when I fell ill, I kind of had to learn the hard way this trade-off, and coming from a metropolitan city like Melbourne, where the neurologist services would have been available at the doorstep for me, I kind of regretted my decision to move to regional New South Wales because, it led to a potentially worse health outcome for me. If that's the case, then it's not only me who suffers from that, but also the business that employs me, which has serious economic impacts, not only on the business myself, but on the state of New South Wales altogether. And that specialized businesses can't attract the required employees to work there.
The New South Wales government does say that it wants people to move to the regions and actively encourages people to move to the regions. New South Wales is a rich state and Australia is a rich country. There shouldn't be such a trade-off, should there?
No, I agree with you, it shouldn't.
Anybody else wish to make a comment along those lines, or I'll proceed to more questions. Mrs. Robertson, you talked about...
You can only leave the witnesses so far, Kate.
I think that was...
Order. You can ask the questions in the way you wish to ask your questions.
Mrs. Robertson, you talk about health service planning, and particularly in relation to, I think you in your additional submission you provided the fact that when you're talking about the last services plan for Northern New South Wales District finished in 2008, that's the clinical services plan, is it?
Yes.
So is it unusual, do you think, for a clinical services plan to have expired for so long? Is it a lack of transparency? Sorry, 2018, my fault. Is it a lack of transparency around that clinical services plan?
No,
or is it just not there?
I'm not exactly sure. No, it's not there. I'm not exactly sure what's happened to the planning department within the area health services that used to actually be responsible for reproducing when something was run out. And obviously there's a rural health plan for the state. I mean, I found it eventually. But it's not very precise about individual services and providers, so it's very difficult to interpret back onto your own area health service.
Do you think there needs to be more transparency? Would you like to comment on the transparency around these plans for health services delivery?
I think we actually need one. I think
that's a good start.
It says so in their strategic deal with the ministry that they were responsible for doing health service planning. And then it seems to have gone elsewhere, and then it's now done. I don't know this for a fact, but it now seems to be done piecemeal. So the funding came for Lismore Hospital, big state funding for the planning, big state planning for Lismore Hospital, and the funding's come for Grafton, and so Maclean's included in that, and so it's big state funding. It's different. It's not a comprehensive local health district plan it's about, and probably the Tweed had the same thing, a health service plan up there. Am I making sense? A consultant's drawn in to do for the development proposal rather than health planning for the community.
Thank you.
Not healthy.
Thank you very much for all coming in and appearing today. It's fantastic to get your insights. Ms. Robinson, I was taken by your opening statement, I think, in particular the bit where you talked about not having, say, neurosurgery on every corner or paediatrics, but what's appropriate healthcare for the area at the time. Can you expand a little bit more on that? Because I think that's been part of the conflicting themes we've had. some people have insisted that they want, every single health service on every doorstep. But people like yourself have said, we just need appropriate healthcare in the regions and then access to other stuff. Can you provide a little bit more clarity around that?
In the old days, in small hospitals, district hospitals, anywhere, you could have babies, you could chop things out, you could do all sorts of amazing things. The outcomes weren't always that good, but everyone loved the doctor anyway, so it worked okay. And then gradually times changed, and people started to demand quality of care. And so people started to demand that they wanted their babies born where somebody was a posh person or whatever. And in the area I used to work in, where he comes from, they were still, I'm not supposed to talk about that, where the Honourable Mr. Khan comes from.
No. Him is just fine, Ms. Rockford.
They were, there were hospitals that still had some maternity that were being hung on to by the skin of their teeth that only the poor would go to, because all the others left town to go to across the border actually, to actually get the treatment. So that sort of stuff gradually changed, and then the delineation process, and then the right place at the right time philosophies came in. This was, both governments have used both of these, so I'm not making a political statement here, but that's what made a lot of difference to the changes to rural healthcare. But it still doesn't mean that you can stick a camera in every single doctor's office and say this is what you got, or without a doctor at the thing to help the person with the camera. I mean, it doesn't mean you replace stuff, which is what seems to be being forced to happen because people's budgets are being washed down. So it's complicated.
Yeah.
It's changed.
No, and I think that's that balance that we need to find, because obviously we want appropriate healthcare in the regions. I live in Wagga, so I want to make sure that the people west of the Great Dividing Range have that. But there's also that law of diminishing returns, where if you don't get the exposure to, say, things like neurosurgery, if you have a neurosurgeon in a small town and they get a case every once a year, they're not getting that exposure, they're not keeping the skills. And that's that balance, isn't it? That, we used to have a lot of services that were done periodically, but the mastery of that skill requires constant training, doesn't it? And is that sort of where that philosophy's come from now, do you think?
Yes, and a long history of incredibly disastrous results for some persons when these things were tried, where they couldn't inherit a school bag. If you're doing maternity, you've got to have an obstetrician and an anaesthetist. GPs used to do that. Now their insurance is so incredibly high, hardly any of them can do it. So that goes away, that goes out of that town. So those things change. So that's changes, but that's not, this inquiry is more about knowing you've got the transport when somebody needs to get somewhere to go and have a CAT scan to see if they've actually got a clot in their head for their stroke. It's more about knowing there's the services to back up for the referral. There's no use having a system, which it talks about. There's no use having a hospital where there's 3 nurses on and you can't get a stitch in your leg.
Well, you raise an interesting point, because I think for many people this inquiry means different things, and that's something that we're, I guess, looking at throughout the inquiry. For some, it means that, like I said, they want a full. They want to be able to have every single service on the doorstep. But other people have provided testimony to us that differs to that, and that's why I just thought your opening statement was interesting, because it actually, I think, went to the heart of what rural and regional communities may need into the future. So thanks for that. I know that the Honourable Trevor Khan had some questions that he might want to ask as well.
Christine, thanks for being here, and I know you have had a great deal of experience with the hospital system in your time when you're in Parliament. So, yeah, good to see you looking so well. Oh, look, taking into account your history, what I'm interested in is we took evidence yesterday in Taree, and I'm interested in essentially the shape of the health districts, and whether you would have a view, and I'll ask particularly in regards to that Taree area, about whether our delineation of, for instance, Manning Base Hospital being in Hutton, New England, is appropriate, or whether it's more appropriate that that be aligned, say, with Mid-Coast Health District. Do you have a view from back then, particularly, as to whether we got the delineations right?
Tara used to be in New England years ago.
And it is now. That didn't seem to...
Tara wanted brain surgery. They all walked out of the meeting I was in because I laughed. I haven't got an answer for the people of Taree might find it difficult to, but that's Newcastle. Newcastle's their community of interest. It's very close. No, I think it's probably appropriate Taree remains with Hunter New England because Hunter New England is now such a huge region, and Taree's community of interest would be Newcastle. I think so. I think there's enough problems on the mid-north coast with things that the government's trying to do there.
Yeah, indeed. So I'll just ask, seeing you were a resident of Tamworth with me.
Not quite with you.
Well, sort of. You're right, if I remember correctly. Sort of Tamworth. Well, we received a small amount of evidence yesterday in Gunnedah from a specialist from Tamworth who was positing a view, I think, that there should be a breakup of Hunter New England into what I assume to be a New England and a Hunter health district.
I'll go back again.
Sorry, you'll go back again.
No, did they? Well,
It assumed that specialist was of the view that was the case. I have a contrary view, I've got to say, but I might be alone.
Yeah.
Have you got a thought?
I think the original decision about putting Hunter and New England together was about knowing that the Hunter and particularly Tamworth Base, which is a very high-level hospital, can share resources and share resources successfully. And so some of the specialty teams from the Hunter are the backups for the Tamworth people, and some of the Tamworth specialists didn't like that. I don't know if I'm supposed to say that politically or otherwise, but that's my recollection of the history of that issue.
And I don't think it's changed, to be frank, so...
Don't tread on my toes.
Thank you very much. I've only got one question. If any of you have had any dealings with nurse practitioners? Nurse practitioners.
Don't know.
Nurse practitioners.
No.
That's fine. That's okay.
Christine?
Yes, I have. It's often very difficult to get them to want to work into the kind of environments for the same reason that we can't get the GPs. So there's nurse practitioners in specialty areas who love it and who go to the base hospitals or the whatever they're called these days. But getting them to actually go and work by themselves at an MPS where they could do your stitch, that's another issue.
That's fine. Thank you.
Just about go time, so listen, I thank you all sincerely on behalf of the committee. It's been very enlightening to have what in effect are very, I'll call them case studies for us to look at in some detail. So not just broad comments about your circumstances, but some details behind that. And as I said, coming forward in a public situation like this and going into your own personal stories is not always easy, but can I say to you, it's those case studies which helps inform us and give us some clarity to what the actual issues are in particular parts of the state as we travel. So thank you all very much for coming along.
Thank you.
And express our thanks on behalf of the committee. Okay, so we'll conclude our transmission of the inquiry because we're about to break for lunch and return after lunch. Thank you very much. This afternoon for our visit to Lismore, and we welcome very much the presence this afternoon from some very senior people. Now, we'll go through the formalities first, if that's okay, the swearing or the affirming of you in for your evidence, and then I'll continue with some further opening statements. Now, the procedure is, and forgive me, you're probably familiar with, but just identify yourself by name, this is your title, the respective organisation, department you're with, and swear either an oath or an affirmation, whichever you prefer, the words of which should be before you. So we'll start with Dr. Hutton on my right and to move across. So thank you, Dr. Hutton.
Dr. David Hutton, Director of Clinical Governance, Northern New South Wales Local Health District.
Thank you, Doctor.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Doctor. Mr. Jones.
Wayne Jones, Chief Executive, Northern New South Wales Local Health District.
Thank you.
And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Mr. Jones. And Ms. Duffy.
Catherine Duffy, Director of Nursing, Midwifery and Aboriginal Health for the Local Health District. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Now, what we normally proceed to, and in this case as well, provide an opportunity for an opening statement to be made. I'm not sure whether there was the intention to have one by yourself or... Okay, yep. With respect to, as I'm sure you know, the government, New South Wales Health, had their omnibus submission, which stands as submission 630 to the inquiry. So that's can be taken as read. All the members are familiar with its content and detail. If you're agreeable, the way I'd like to proceed, and I think we nearly got all members back to the table, just about. We've got members from government, National Party, the opposition, and crossbench. So there's a good reflection. I don't need to go around the table. You can probably see the labels, but we're all here. Kate should be not far away. So, big vote. Oh, getting a photo taken. Well, she's a politician, so we'll give her a bit of grace. I think I've seen you in a photograph before as well. That was about provide you with the opportunity for the opening statement. If you're agreeable, we'll open up for questions. And what we do, we share it around between ourselves and work through whatever questions which may arise from your particular opening statement, but more likely, in addition to that, other matters have been raised. So are you comfortable with that?
Very comfortable. Very comfortable.
Okay, well, once again, we know you're extremely busy in your role at this time with the matters going on, as we know, over the last 12 plus months, now 12 and a half months. So thank you very much. We know your time's very precious, so thank you very much.
Thank you very much. Before I start, I'd like to acknowledge the traditional custodians of the land in which we meet today, and that's the Witjable Waible people of the Bunjalung Nation, and pay my respects to elders past, present and emerging. And whilst I'm here, I'd like to pay my respects and extend that acknowledgement to the other Aboriginal nations on which the land of our organisation is, and that's the Yagal, Gumbaga and Gidabal people. It's a privilege to live on the North Coast and to work in the North Coast. It's a very diverse community, and it's a community that uses that term frequently. We are very proud of the service in which we provide as an organisation. We've seen it grow exponentially, particularly over the last 5 to 6 years. We service a population of around 300,000 people, and that population is growing. For us to service that people, we need to continue the planning that we've been doing over a long period of time. We need to ensure that our planning is nimble and flexible for the demographics and the changes and the ageing that we're starting to see. There is a need to be on the forefront of delivering innovative and sustainable models of care. But we can't do that alone. We need to work with our partners, and we work very hard to develop services that reflect the community needs with our partners. And just to name several of those, it's the Primary Health Network, Healthy North Coast, our local general practitioners, Aboriginal medical services, and a range of non-government organisations. Our partners include our community, very much so, and we've gone to great lengths in the last few years to revamp our community engagement plan and framework that's been put in place to support to proactively engage and meaningful engagement with the community, so we understand the issues that matter to them, not just the issues that we think matter to them. And so we've worked with them over a number of years now on co-designing services that meet their needs. This includes the development of the Benalbo MPS, the Corokai Health One, and we're in the process now of developing the Clarence Valley Health Services Plan and the Ballina Regional Health Services Plan. It's recognised that we have roughly 220 hospitals in New South Wales, and we cannot provide all services to all people. So we need to network services. We're no different to any of the colleagues you've heard in south and west of this state so far. We have internal networking. We're from the smallest hospital, an MPS, up to our larger facilities at Lismore and Tweed, Our role is to ensure we understand and recognise the conditions that they present to, and there is an escalation process to allow them to receive the right care at the right place. In addition to our internal networking service, we have a very good relationship with Queensland Health and Queensland Hospitals, particularly the Gold Coast University Health Campus, where we have a cross-border committee arrangement with them, and we meet regularly to discuss issues and concerns. And our goal is to ensure that our networks provide the right care at the right place at the right time. And at times that means transferring them to another facility. I want to assure the committee that any decision to transfer a patient from any facility is not taken lightly, because we're taking them away from their home. And so we take those decisions based on clinical advice. And the only advice we listen to in transfer are the clinical advice. And it's to ensure that the betterment of care and the betterment of the treatment for that patient. One of the challenges we have, like all health services around the world, is recruitment and retention of highly skilled workforce. As you've already heard, geography plays a large part. As a district, we're committed to boosting our workforce, and I'm sure throughout the questioning we'll be able to give evidence where we've done that considerably over the last few years. But we need innovative models to recruit and attract. And several that we've worked with is with the University Centre for Rural Health and the partnership with them and our regional training hubs, which link medical students across the region here from their undergraduate years through to their intern years and ongoing. So they remain here ongoing and have a career path within our organisation. Our workforce growth, we've seen over 1,000 new staff in the since 2012. We've seen 170 additional doctors, 360 nurses, 120 additional allied health staff. To support our growth and to recognise the demands we have as an organisation, we have had a capital development boom over the last few years. We've had over $1 billion invested in development of capital within our footprint. At Lismore Base, we're in the final stages, thank goodness, of the redevelopment there, $320 million. If you saw Tweed, the Tweed Valley Hospital is fast coming out of the ground. It's a $670 million investment. Not only to replace the Tweed Hospital, which is a tired, fatigued building, it's to provide additional services, cardiac catheterisation services, radiation oncology services from the get-go. This is all about reversing flows that we're seeing go to Queensland. I want to take this opportunity to acknowledge the staff in which work in our organisation, our clinicians, our non-clinicians, our support staff, our wardsmen, everybody. They all come to work to do a good day's work and to do the best they can. Without their compassion and without their dedication, we would not hold the standing that we have within our communities, but also against the key performance indicators we see in quality and safety and others. Our staff are our backbone, and we go out of our way to acknowledge that with them and to support them as much as we can. And as the Chair's pointed out, the last 18 months in particular has been incredibly challenging for all our staff. As Chief Executive and on behalf of the District, I welcome this inquiry and the opportunity it presents for our communities and staff to have a voice and share their experience. I'm hopeful that the inquiry delivers recommendations which are meaningful and actionable and can support the ongoing positive changes that we've seen developed in our organisation. Thank you.
Thank you, Mr. Jones, for that comprehensive opening statement. Excuse me. I'm wondering, Josh, in terms of the time allocation, can I suggest 3 tranches of 15 minutes, which gets us to 3, and then 3 lots of 10, which gets us to 3:30. Now, obviously, if we need to sort of adjust the last lot because there's been a bit of slippage, we can do that. But 3 15s, does that work for people, or would you rather do 10-minute blocks?
No, I'm happy with 15, but could I suggest...
Yeah.
Not so much, I think, for us, because I don't think our questioning will be that hard. But depends if I take my medicine. But that the crossbench and the opposition have an opportunity of an extra 5 minutes, which can then be adjusted at the end, just in case if Walt gets on a sense of blood, that he can follow through for the extra 5 minutes.
Okay. So yes. So
sorry to put you in it, but
can we handle up to 20 minutes? So 10 each. So and then we've. Does that work okay for you?
Yeah.
Okay. So we'll do it. Thank you for that difference. So we'll tune 20 minutes, and then we'll make an adjustment to sort of provide opportunity for the government to deal any matters they wish to do. So thank you, Deputy President.
Thank you, Mr. Chair. And in the spirit of a suggestion from the Honourable Trevor Khan. Mr. Jones, why is Lismore Base Hospital booting out patients in the middle of the night without transport, without any means to get home, in cases without a wallet, without a telephone? Why are you guys doing that?
Let me start the answer, Mr. Secord, by saying that is not our normal practice. Our clear direction to services and staff is that when you're transferring someone, whether you're discharging someone, and the people you're talking about there are people who are discharged from the emergency department, not from the ward areas. And when you're sending someone home, no matter what day or night, and it's important that you factor in a whole range of requirements. Transport home, particularly in isolated regions, is one of those. And unfortunately, we have failed in several of those occasions. But I can tell you it is not the standard of what we try to achieve, and we failed those individuals that have presented that information. We have put memos out to staff reminding them. We've increased our in-service about transport. We've increased our own PTV, patient transport vehicles locally. We have community transport contracts, and we have a clear position that particularly after 8 p.m, if people can't get home, then we're to find accommodation for them or transport. Unfortunately, as I said, we need to acknowledge that we failed a small number of people.
Now, you said in your answer that that refers to the practice in the emergency department. So,
No, it's primarily the patients in reference that the witnesses have given so far reflect emergency departments.
now, I mean, it's also been put that in fact, discharging people or getting them out of the emergency department or the hospital quickly is about the the lack of beds, in the hospital. In fact, it's a way of freeing up beds to get other patients in.
That should not be the case. There is no disputing emergency departments are busy. The last quarter results from BHI show that the number of ED patients coming through our facilities is second highest on record. So we are busy. There is no disputing that, and Lismore is one of those facilities. We do not discharge people because of bed pressures per se. Patient discharge and admission is a clinical decision. What's occurred in these circumstances, the decision has been made to discharge a person home, and unfortunately, due to lack of complete preparation, they have been discharged out without transport home. But I emphasise again, sorry, I just need to really repeat this. These are rare occasions in our service, but we take them on board. We should never have failed anyone in this circumstance.
Now, Mr. Jones, what's Code Black?
Code Black is an escalation of an emergency situation. A perfect example I can give you is recently we had a bomb scare, a phone call into Byron Central Hospital only a number of days ago. The Code Black is triggered, and that requires an escalation of concern. The executive need to take control, and the response varies depending on what it is. In this case, the relevant support services, police and fire, were called, and the facility was put into lockdown.
Now, are there other circumstances when a hospital goes into Code Black? I'm not talking about dangerous circumstances. Well, maybe dangerous circumstances, but not external threats to the hospital. What are other occasions when a hospital would go into Code Black?
Oh, when you have risk of incendiary devices, not just bomb threats, but malfunction of equipment. You can have situations where there's an escalation when there's absolute gridlock with beds. I think that's what you're leading to.
That's what I was leading to.
There are situations which then escalate the need to engage the executive team to actually get engaged in what's happening with patient flow. They should be at that point in time anyway because it's escalated up. And then there's a range of actions that trigger that, with the DMS going around, Director of Medical Services, going around working with the consultants to see about discharging to create additional bed flow.
Now, when you're talking about bed flow, so when a hospital gets into Code Black involving beds, what's the figure? I think it's 140% capacity. Is that correct?
No, there's no real figure set there, Mr. Secord. It's just when you're at capacity. And when there's no other beds you can identify, and it's created a situation of exit block out of your emergency department, which then has a flow-on effect of delays in ambulance offload, as an example. So once those figures reach, and we don't have a key line in the sand here because there's a number of variables there. If there's resus patients coming forward, a whole range of different, what's the type of patient waiting for admission from the emergency department? So we don't have a set in stone set of occupancy or criteria. It's when there's effectively inability to transfer patients out of the emergency department for an extended period of time.
Does this happen very often at Lismore Hospital?
No, it happens infrequently, but it does occur.
So what happens when you reach code black and the hospital is at capacity and there are no beds? What do you do when that happens? Is that when you turf people out, kick them out of the hospital? Is that when that occurs?
No, we never turf people out, kick them out of the hospital. We work with the consultants, the admitting specialists of each of those patients. Are there patients who are ready for care elsewhere? Yep. Are they reaching a level where we can put them to a district hospital as opposed to our base hospitals? Are there patients who are ready for discharge? Are there patients who can be transferred into our hospital in the home program so they continue the delivery of care but in their hospital in a community setting?
So can I ask you, does it happen very often when Lismore goes into code black and you reach capacity and there are no beds left?
There certainly are occasions where we identify patients an inability to address all the pressures in the emergency department.
Okay,
but
has it happened this year?
I have not had a situation where we have not been able to ease that pressure. Maybe
Okay,
not
but that
completely
wasn't my
relinquish it.
question. My question is, does it happen very often at Lismore Hospital when you reach capacity, meaning that all the beds are full?
No, because most of the time you're pre-planning. You're seeing that the patients are filling up in ED. You're seeing that your elective surgical activity is coming through. So you're already preparing for what comes through. We know on average how many patients come through our emergency department any day.
Okay.
We know how many elective surgical patients are booked. So if we see there's a clash there are times where we need to cancel elective surgery because we need those beds. And there are times where we need to look at facilitating discharges. As I said, it varies.
Okay, so how many times in the last, I guess since the beginning of this year, you would know as CEO, has Lismore Hospital gone into code black where you're reached capacity on beds?
No, I don't know that number. I can tell you it's a small number, but I'm not sure of the exact number.
Can you take it on notice for this year and for 2020? The number of times that you've reached code black in relation to capacity of beds.
We can certainly take that on notice and provide that.
Now, you mentioned in your answer previous to my question about cancelling elective surgery when you reach that point. What happens when that occurs? And how many times has it occurred this year?
Again, the exact number is not something that, as a chief executive, I need to be aware of.
Well, it must come to your attention when it occurs.
No, it doesn't. We look at the figures on a trending basis because a lot of times these patients are rebooked. It's when they go overdue that it becomes to our attention.
What's overdue?
When you're booking someone for elective surgery, clinicians book, they determine the clinical status. If it's category 1, then they need to be done within 30 days. If it's category 2, within 90 days. Category 3, within 365 days. So if they breach those category timelines, then they're overdue. So I get a report on a monthly basis where we're sitting with that activity. So, sorry, I apologise, I'm distracted. I can't remember your question. I apologise.
It was about the cancellation of elective surgery.
Yeah, I don't know the exact number. What we do know is that we are continuing to work on, okay, if I'm cancelled, if we're looking at cancelling, then it's a clinical decision on prioritising what that is. So we contact our theatre management team, operating theatre management team, and with the anaesthetists and the surgeons, we go from the lowest clinical risk to the highest clinical risk, and it's managed in that way. There are some cases, for example, that you just don't cancel, no matter how bad your B block is. They need that operation today.
Now, we had evidence earlier in Sydney. It was one of our very first hearings, and there was a Dr. Evel, spelled evil, double L, but Dr. Evel, and he expressed his frustration about the new ICU unit at Lismore Hospital. So, what is the current status of the ICU unit? Is it up and running now?
No, if I can spend a minute to explain where we were.
And I'm going to ask you a few questions about this, so take your time.
I'm sure you will. The new ICU was ready to transfer, and it was approximately January of last year. And 2 days before we were ready to transfer, the New South Wales Nurses and Midwives Association put a claim in for additional staff. We were considering that at that point in time, and then COVID hit. And the reality is the clinicians, we pulled together a lot of consultative work with clinicians. We needed an ICU that had more isolation than our current ICUs had, because people will remember the beginning information we had was devastating. What we were seeing overseas was unbelievable. So the clinicians decided the best place to house our COVID positive intensive care patients was Lismore Base, because in the new ICU, because they were self-contained rooms.
Can I interrupt you there, because this is interconnected with the COVID and the ICU. So are there, without breaking any confidences, are there any COVID cases in the local health district at the moment?
We have recovering COVID cases.
Okay, but the other people in hospital,
No.
in the ICU?
No, we have no COVID ICU patients at this time. But as I said, we need to go back to what people were expecting to come through the door, and we need to prepare for that. So everyone agreed. No one argued that we needed that new ICU. So that was our COVID ICU, and we did end up having a number of patients cared for very well in that ICU. We continued then. The new ICU was split into two zones. We could close off one zone because we needed to progress our vaccination program, and the agreement was to start our vaccination program in one of those zones, pending resolution of COVID ICU and also the industrial action. In the last month, we've had an agreement, we've broken an agreement with the New South Wales Nurses and Midwives Association on resourcing for that unit, and the Nurses Association, Nurses and Midwives Association, the clinicians and management have set a date as the 22nd of July to move that unit, the old unit, into the new unit. Part of that delay is to allow us time then to set up the new public vaccination clinic at Lismore Square, which we've done, and to relocate the staff clinic into another facility. It's been many dominoes and issues we've needed to work through. It's been very complex.
Okay, so there are no active COVID cases in Lismore Base Hospital at the moment, but the ICU unit was originally set up in case you needed it for COVID. So, okay, so now we're probably about 15, 16 months into COVID now, and what are your plans to actually open up the ICU unit?
It's planned. We've had negotiated. We're working with the staff, and it will transition to the new ICU on the 22nd of July.
22nd of July.
Yes.
So that's when it'll be open.
Yes.
Now,
sorry, pending any major issues that come up between now and then, the agreement with the association and the staff is the date is the 22nd.
Now,
Well, can I jump in with a question?
Oh, yeah. Okay, I was just. Okay.
So plenty.
I was assembling something.
I'll keep assembling.
Don't give me time.
This is the old left-right, so now it's my turn. No, Mr. Jones, as we've been, and this is our 8th hearing, travelling around the state, hearing evidence, the phrase has been used from individuals and stakeholders that it costs more, as a general statement, it costs more to treat a patient outside of the large metropolitan areas. It costs more to treat a patient in a hospital, a general statement. I don't know whether that's true or not. As a matter of fact, I just do not have the knowledge and the information to be able to establish that one way or the other. We understand that the way in which New South Wales Health operates in terms of its funding is that it purchases services. That's the way it operates. That's its fundamental underpinning, the modus operandi. Now, if you don't know the answer, just simply say so. With respect to the purchase of the services that are undertaken, and if we look at it in a local health district sense now, you're responsible for a local health district, are you aware that the sort of calculus that's used, the formula that's used to purchase the service contains an assumption or a condition of its calculation that because this is outside a major metropolitan area, there actually is going to be an extra cost associated with the treating of that individual because they live outside a major population centre?
There are some components to the funding called residual operating cost, and I'll come back to those in a second. But I will say, since the implementation of activity-based management, activity-based funding, where we now have a national efficient price, which has a national weighted activity unit, down to a state efficient price, it's my understanding and my experience, particularly over the last 6-7 years, that there's been incredible equity in the allocation of funding to rural in regard to running a hospital service. I get the same NY value as a metropolitan, my equivalent at metropolitan LHDs. So, but it is recognised through the funding process that some rurals, for example, locum agencies, we're talking about ongoingly the difficulty in recruiting doctors, and we're all reliant on locum agencies to fill those gaps at times. So some of us have locum agency rates. We've been sitting on about 22% of our VMO numbers have been locum agencies for a number of years now. That is slowly but surely dropping as we're getting some traction now in recruitment in places like Grafton. But it's recognised that locum cost is more than employing a VMO. So there is recognition in the funding cycle that you have some residual operating costs you can't fix, but we need to support you going through that. So it does accompany a few of those. You've got the locum rates, there's a couple of others in there. I don't understand them that much purely because in a sense it doesn't apply to us. So that there is a component in recognising rurality in the funding cycle.
So that, and I'll pass back to my colleague in a moment, this amount that you've described, does that sit as effectively a pool that you can access in your capacity as a CEO, that you're able to sort of utilise it to provide you, with some flexibility perhaps to deal with what could be contingencies or changing patterns within your area of responsibility, your LHD?
I think it's more recognition of cost, not so much allocation of budget. And how it's actually managed, I cannot tell you because it's not something that we apply too often in our LHD because of the way we've managed our budget. Despite we've had considerable growth in budget over the years. In the last 5 years, we've seen a 32% increase in budget. Last year alone, we saw just under 4.5% or $39 million increase in budget. So that's reflecting an increase in activity. So we've been able to manage our activity and our budget over the last few years. So we have not, we've not availed ourselves to the necessary detail of going through that. So I apologise, I can't answer that question.
And we'll just cheat for one final question now. With that activity you've just described, in terms of looking at the forecast for the following year, are you actually assuming in an extension of an activity into the future that's likely to be the same or different? In other words, is there forecast built into looking forward as opposed to looking in the rear vision mirror?
Without a doubt. When you're looking, there's a lot of negotiation with the ministry that take many months leading up to the allocation of the budget. It's based on your population, your growth in population, your trend in activity, and a range of other variables. For example, if you're building a new service, if you're building a new hospital, what are the costs in going for that? So there is quite a strategic view. It's not just looking at the rear vision mirror, this is what we did last year. There's also an activity and an opportunity for us to negotiate what we can do or need to do next year. So no, it's both.
Mr. Jones, how many hospitals in MPSs are in the local health district?
We have 8 hospitals and 4 MPSs.
Now, those...
I can also add, sorry, just to completeness, we have 3 health ones and 19 community health centres.
And how many health centres?
19.
19. Now...
That trick only works once.
Yeah. No, I'm going somewhere else for this as well. So we've had previous inquiries in Deniliquin, Cobar, and that, and there was quite a consternation in the community about the use of telehealth.
Yep.
Now, with those the MPSs, the health ones, and the 19 smaller health operations, how many of them are reliant on telehealth?
Reliant, I'd say.
Or use telehealth?
Oh, the majority of the MPSs do.
Yep.
Because we put in what we call critical care cameras, and it allows them, if they get a patient coming through, even with a GP, GPs have a scope of practice, and sometimes patients can present that beyond that scope of practice. And when you don't have a GP, you have nurses there who are trained in first-line emergency care, FLEC nurses, you might have heard that term already, providing that. But it allows visualisation back into a base, Lismore base, for example. I'll use Benalbo as the example. Benalbo gets a patient, they want that, the critical care camera goes through in that regard. We are fairly fledgling on our telehealth, virtual health programs in our footprint. It's not something we've invested in heavily historically. It's something we're certainly moving on in developing, but we certainly see it as an adjunct, not a replacement.
Okay, can I ask you one quick question, because I am aware that my time is running out. So would you be able to provide that in southern New South Wales, there were a number of hospitals, and in western New South Wales, a number of hospitals indicated that they were without doctors on weekends. How many of those hospitals, of the hospitals within the local health district this year, had weekends without a doctor on duty, without a doctor physically in presence, and had to rely on telehealth?
Can I just ask for clarification?
Yes.
Do you want to include MPSs in that, or you're just referring to hospitals?
No, MPSs, as well as all health facilities under your purview.
If I can talk hospitals first.
Yes.
We work to staff all our emergency departments and hospitals 7 days a week.
Yep.
There are occasions where, due to illness and last-minute unavailability of a locum, no matter what we try, there might be a shift where it's not covered, despite our best intentions, but they're very unusual, very rare, and getting rarer because of the changing model we've implemented in our district hospitals in particular. The MPSs tend not to have a doctor rostered over the weekend, but they have access again to the critical care camera, and they have access to further supports.
So MPSs on the North Coast here generally don't have doctors on weekends.
Correct.
Thank you.
Honourable Emma Hurst, Deputy Chair.
Thank you, Chair. I just want to ask a couple of follow-up questions from the last questions that were just put to you. You mentioned that people shouldn't be being discharged in the middle of the night without accommodation or transport available. Who pays for that accommodation or transport?
There's a range of ways we do that, and I mean, there was a presentation earlier with Sharon and so forth. Sorry, Sharon Bird. We're a small community, we know each other. We do encourage people, if they have family and friends, to transport them to do so, because their reliability, they're more timely in that regard. So I need to state that up front. We do rely on family and friends supporting at times. So if we're organising transport, then the cost would be borne with us.
All of it? The entire?
Yeah, if we needed to transport someone back because they had an inability to get back, we use things, not so much with Bonalbo, taxi vouchers, so forth, but in those circumstances where people can't get back and they have no transport, the normal process is that we'll organise transport primarily through our patient transport vehicles. Ambulances don't do that sort of work, understandably, it's not clinically required, so we enhanced our patient transport vehicles, so we would bear that cost.
And what about accommodation? What if someone was discharged in the middle of the night and maybe a transport vehicle's not easily available?
In those sort of circumstances, if they negotiate with us, talk to us in the ED and so forth, and they can't get home, we invariably bear the cost of that accommodation.
And you said that they have to negotiate with you.
So I think negotiate was a poor choice of words to raise that concern with us.
And does it require that person? I mean, I imagine some people might be embarrassed or afraid to bring it up and not realise that there would be a potential service available, and they might be the people that are falling through these cracks and actually just walking out the front of a hospital and saying, well, now what do I do? Is there something, you did say that, you wanted these services to be available to everyone and that you're concerned about the people that had fallen through the cracks. What's being done now that you've heard that there are people that are experiencing this? What's being done to correct it?
The emergency departments have been reminded that no one should be discharged after hours. After 8 p.m. is roughly the time we use, that people should encourage, the staff should be talking to you if we're ready to discharge you. Not rely on you raising the issue with me, but how are you getting home? Do you have a way of getting home? That should come from us, where the person can then comfortably say, well, I do have a challenge, and we should not be discharging them out the door until we're comfortable they have a way home. And if the nurse, for example, says I can't, then we need to escalate that up either to the clerk on shift or up through the assistant director of nursing of the hospital at that time to organise something different. There have been occasions where this has worked well, where we've organised transport or we've organised accommodation. But as I said, I think you've summed it up quite well. I think it's my take that the staff have not asked, and therefore people have been too proud or embarrassed to raise the concern directly.
So has there been some training or some staff communication to try to change that?
Yes, there has. Yes, both.
And you said that nobody should be discharged after 8 p.m.
Can I add to that? Sorry.
Yep.
Part of the things we've implemented, we were very fortunate to be one of the pilot sites of the emergency department concierge model, which put, people understand what a concierge is, someone in the waiting room, the emergency department, and to see how that worked in not only easing the tensions in the waiting room, but to also support people. It's been an absolute overwhelming success, and we've got that about 14 hours per day in our bigger hospitals. We've got it at Grafton, Lismore, Tweed and Ballina. And that person, when you walk in the door, we're finding it particularly useful for elderly people, a reassuring smile. It used to be a reassuring handshake, but with COVID, it's just more a reassuring smile now. And that person works with them, not only in the waiting room to ease their concerns and tensions, but if there's an issue on transport when they're on shift, the concierge work greatly in supporting that. So I apologise, I've forgotten that.
That's right. And you did mention that nobody should be discharged after 8 p.m. If you did get to one of these situations where you were over capacity and that happened late at night, what happens then if you're not to discharge people?
So it wasn't my intent to say no one discharged. No one should be discharged without a plan of getting home.
Okay.
I mean, obviously in an emergency department, you can be discharged or released at any time of the day or night, depending on your condition. What we emphasise with people is you need to take in the holistic care of that person and make sure that they have a way of getting home, that there's somewhere to them to
And
go
so
home.
what's the difference between before 8 p.m. and after 8 p.m? Are you saying that if someone's discharged before 8 p.m. that there doesn't need to be that emphasis on making sure they have a way to get home?
We tend to find that up until then there's more services available and the problems are less. It's when after 8 p.m. when there's less staff that we tend to find that. No, what I'm emphasising, and this is 24/7, but we emphasise in particular after those hours, that should be something people should be in front of their mind.
And I just want to ask you, we heard a lot of, from the submissions, they reference the fact that a lot of people are being forced to drive many hours over the border into Queensland to access medical care. Is this a concern that's been brought to the LHD?
Cross-border flow, as you can imagine, we sit on the Queensland border. We represent about 48% of the state cross-border activity, and on a raw volume of head count, more Queenslanders come into our footprint for care than New South Welshmen go across the border. Queensland take up about 20% of our elective surgery work and about 25% of our ED activity in Tweed. So we do that. So there is a network of services with Queensland, as I said earlier, that works very, very robustly. And we are aware of that transport and that difference. So over the years, we've set up a number of services, radiation oncology services at Lismore to stop people travelling, cardiac catheterisation services at Lismore to stop people travelling, Tweed Valley, both services will be implemented there within 2 years. All of this development is to meet the needs of the local community, but part of the offset to that is to reduce flows. We anticipate that we'll see about 5,000 people return back and get their services locally once we complete the development of Tweed Valley Hospital.
We heard evidence today from a patient that was regularly travelling to the Gold Coast, and he had heard from, I believe, one of the practitioners working in Queensland, that Queensland were actually considering making some kind of decision to stop people that live on the border into New South Wales from coming up to Queensland to be treated. Is that something that you have heard? Because obviously it's causing a lot of stress to the people that rely on the Gold Coast.
It's one of those stories that come up every now and then, and we respond to it immediately. I can give you a recent example. A cardiologist at the Tweed Hospital called me about 8 o'clock one evening, this goes back about 3-4 weeks, maybe a little bit longer, and expressed his concern that he's hearing Gold Coast won't accept our acute cardiac patients. He obviously was very concerned about that. I contacted the chief executive at the Gold Coast. This is part of our communication relationships. We have each other's mobile. I raised it with him, and that was following that discussion. He sent me formal advice that killed that completely. So that's not the case. Every now and then we need to kill this comes up, but it's important we recognise the level of activity in South East Queensland, and we don't want our patients denied care. We have a cross-border committee that looks at flow. We develop pathways, trauma, stroke, as just 2 examples. And the deal is that if we can't manage those patients because of acuity and they need to go to super specialty services, then they accept them. The quid pro quo is that as soon as they're ready for discharge, we take them back. So
there was also obviously a lot of stress for people who were relying on services in Queensland during COVID border lockdowns. And obviously that sort of came, a lot of people were unprepared obviously for a major outbreak like that. But what is being done now for people who are relying on Queensland services, given we're still not really out of the woods as far as COVID's concerned, or future issues where we have further border closures?
Very timely question. I understand that there's been a further border restriction implemented today.
I live in North Bondi. What's going on?
Read the text.
Can I go home?
But in all seriousness, the border closure was a very unfortunate situation to have to manage. It did create a lot of emotion and frustration. I can tell you from me alone, let alone the poor patients who needed to get across the border. It created a degree of confusion. But over a matter of several days, we negotiated with our Queensland government, we have contacts with them and with Queensland Health Services, that there would be no delay in emergency transports. The hard border block, there would be access for emergencies to go through. That was not stopped. Where we had challenges were those non-emergency transfers. Those patients who had visits there, we negotiated on an individual basis. If you had an urgent need to go and see a consultant because of a range of services we don't provide here, we negotiated exemptions and so forth. But it did create a degree of confusion and anxiety that was unfortunate.
And going forward, is there anything now in place for some of that non-emergency stuff and for family and friends and stuff if somebody is put up into Queensland?
We've had to be fairly selective in what we can do in that regard. One of the clear increases we've done is our cardiac catheterisation service at Lismore. It was about 4 days a week it was operating on. What we saw with the hard border lockdown was created a clinical risk. So we've expanded that to 5 days a week. I've met with the cardiologist only last month and the nursing staff. We're training more. The rate limiting factor in increasing it even more has been nursing staff. We could not recruit experienced cardiology nurses, cardiac cath nurses, so we're in the process of training our own, and by the next roster we will at least have 5 days a week and on-call for the weekend. So it's that sort of services that we've deliberately increased based on the border closures. Other services we're going to have to manage it case by case as we did before, but as I've publicly stated, I would encourage anyone not to close the border to health services. If there's a need, we can support. There was a negotiated agreement that we're hoping, I understand, and I apologise, I just have not heard the details about today's announcements, but I believe what we call our border bubble, and that's all services and populations up down to just north of Grafton, have free access across the border. We negotiated that with the Queensland Government following the last border lockdown, but it doesn't stop that delay going through traffic and so forth. I emphasise it's very unfortunate.
Thank you, Chair. I just wanted to go back to the issue of transport out of Lismore Base Hospital of the evening. You mentioned in response to questions that there's been some changes made in relation to people not being booted out in the middle of the night. When were those changes made? When was the instruction given to Lismore Base Hospital staff to not do that?
There weren't changes made. It was always been our position not to do that.
Okay.
We've reminded people that should not occur. And I emphasise again, it's unfortunate those errors did occur and people paid a price for it. And we've apologised to those people where we could, where we knew who they were, and we've reminded people that should not be the practice.
Because we heard, of course, I think you referred, there was Mrs. Bird's evidence earlier. However, in the submission from the Old Benalbo CWA, they refer to the fact that there seems to be an overwhelming issue with the hospital releasing patients at all hours. Many of us have experienced the call at night to say they have let me go home and said I cannot stay inside until someone comes to get me. I know that this is not an uncommon complaint and has happened to so many people. So this was repeated today. We didn't hear from the earlier witnesses today with respect to Mr. Jones that this issue has been resolved. So I just wanted to, so it's not a hospital policy, you're saying, correct, that people can't be discharged if they don't have transport or somewhere to go to?
No, there's no policy in this regard. Our practice is to ensure that when we're caring for people in the emergency department, we've dealt with their clinical presentation and they're ready to go home. Our practice is that they should be asking, how are you getting home? Are you all right to get home? If there's an inability to get home, we should be supporting them either in getting home or finding them accommodation until there's an available relative friend to pick them up.
So it's a value statement, not a protocol?
Correct.
So do you have still in place then I understand it was potentially part of the Premier's, one of her 2019 priorities around hospital services. I just wanted to see whether the LHD here still has in place KPIs around emergency treatment performance.
Yes, we do.
So that is where, could you explain what that is in terms of the 4 hours?
Emergency treatment performance is an indicator based on research and history and evidence, that shows conclusively that if you keep patients in for too long in the emergency department, they're more prone to misadventure, mortality and morbidity. You need to get them out of the emergency department. A whole range of factors there, congestion and being cared for by relevant experts. So the decision's been made, and it's relatively consistent, is that that period of time is 4 hours. So I present to the emergency department, the triage, the clock starts ticking. So once that clock starts ticking, I need to be assessed, triaged, assessed, diagnosed and treated and dispatched. So either admitted or discharged appropriately within that 4 hour period. But I stress, any decision to admit or to discharge is a clinical decision. And at no time do we put any pressure on clinicians to make inappropriate decisions on admission and discharge based on ETP.
However, you do have KPIs in that regard to meet the emergency. You've got emergency treatment performance. So I looked it up before just to make sure I had it right. You do have KPIs in that regard?
Correct.
So if there are people, say, who come into a particular hospital at 9 o'clock at night with something where they're treated from several hours away, they made it to hospital, they're treated. It's better for you, though, in terms of meeting your KPIs, if they are discharged at 1 a.m, than staying the night, even if there are beds available. So it sounds like it's more an issue of meeting your performance indicators as opposed to an issue of not enough beds.
No, I reject that wholeheartedly. At no point have we raised this with any of our clinicians, and with due respect, I've yet to meet an emergency clinician, be it medical or nursing, who would adhere to that. If I gave them that directive, that would be rejected outright by them. So I emphasise again, there is no directive, there is no influencing from my office or senior management to convince clinicians to discharge someone based on a KPI. They discharge them based on clinical advice.
Dr. Hutton?
Can I just add there that for the past 12 months, the KPI is only applied to patients that are admitted to hospital, not for those that are discharged from the emergency department.
For the past 12 months, so that's that's in terms of transferring them somewhere else. You're saying within the hospital system.
The KPI used to apply to both patients that are discharged from the ED as well as those that are admitted to hospital, but for the past 12 months, it's only applied to those that are admitted to hospital.
Okay, Dr. Hutton, that's useful. Is that for the whole? Do you know whether that's for the whole state or just this LHD?
That's the whole state.
Okay, thank you. We heard from one of the local cancer network people about what I understand is their advocacy for a dedicated cancer care coordinator in the area. Are you aware of the need for that within the community, Mr. Jones, and whether you've received any request for that locally?
I believe you're referring to the Ballina Cancer Advocacy Group, not specifically from them, but there is always encouragement from our cancer support groups, and we work with most of them in this regard, to improve cancer services, and we've improved cancer services over the last number of years. As I said before, local radiation oncology services. We have increased our cancer care coordination. When we talk about cancer care coordinators, we need to recognise it's not a singular term. We have multidisciplinary team coordinators that manage cancer. We have nurse practitioners, a part of their role is coordination. We have breast care nurses, part of their role is to coordinate. We have prostate nurses, who part of their role is to coordinate. And we have social work staff, part of their role is to coordinate. So it's not a one role that does it, and we have a number of positions on that. But we acknowledge, we review this on a regular basis, and there are times we need to increase those numbers as the number of cancer patients increase. The sentiment expressed by Maureen this morning, the Ballina Cancer Advocacy Group this morning, is one we share, and we work with them, and when there's a need and the demonstrated need, we respond to that.
There was a number of cases that they presented to us in terms of people not being informed of their options after they've left hospital. So that is a concern, and it seems a reasonably simple thing to solve, if you like, in terms of having a coordinator that is there to assist them like other areas have.
Correct. As I said, we have a multitude of cancer care coordinator roles in different designs. My understanding is, and I'm happy to be corrected, the two cases that were put forward were both treated in Queensland and discharged from Queensland. And what that demonstrates to me, sorry to interrupt you, is that we need to improve our communication or remind people to improve our communication with Queensland as they discharge out to our facilities, which is normally the case. And you're correct, the situation, the man with the prosthesis, as an example, that is publicly provided. And if they were referred to us, that is something we would have reminded them of. But that is a gap that's happened in that situation.
Okay. There's also, do you think it's acceptable, you would have heard the earlier evidence as well, that a person has to wait 14 months to see a cardiologist? It's certainly not something you'd want to wait 14 months for to see a cardiologist. Do you agree, Mr. Jones?
I think waiting 14 months to see any specialist is unfortunate. But I'd need to see... We occasionally get complaint letters or letters of request for local MPs or direct from patients saying, I've waited this long to see an orthopod, I've waited this long to see so-and-so. We investigate those and understand why. Invariably, we tell the people that you've been categorised as X, so you need to go back to your GP and escalate your categorisation back through the consultant. We can't influence, per se, the access to the consultant. It's a GP to a consultant process. But in our case, I can tell you we have 4 cardiologists at Lismore Base, and they provide a roster to cover 365 days a year, not only on site but on call. So we have a fairly comprehensive cardiology service. I can't speak of delays in referring from GPs to the consultants themselves, but I would agree with you, 18 months is a long time.
14 months it was.
Sorry, 14.
And the cardiologists at the hospital provide services to public patients as well?
They do. They have their rooms, their private rooms, and they provide services in the public hospital. They have appointments at the public hospital.
Does the LHD have a current clinical services plan?
No. What we have had, has already been presented by Ms. Robinson, earlier this morning, is that our last one ran out in 2018, and it was quite a voluminous document, and it's not the type of document that I support. I prefer it to be more
At least
focused.
it was a plan though, Mr. Jones.
Let me fill in the gaps there. So we were actually looking at doing it. We also had that period of time, and this is not an excuse, it's a practical barrier we had. Our Director of Planning and Performance had retired, and we're in the process of recruiting our new Director of Planning and Performance. So there was a delay there, and that delay ended up being a bit longer than we wanted. And when we started the process, we did start the process, and it was going very well. There was a lot of consultation. Our board chair and another community member were co-chairing the development of the plan, and then COVID hit, and so we've had a delay. What we can say is we are not absent of planning. We have a strategic plan that directs the pillars of which we need to develop to complement what we need to do in the absence of a health services plan. We've developed a service direction statement so people know where we're going with our service directions. It's a more focused document. We've had a very comprehensive clinical services planning for the Tweed-Byron network with the development of the Tweed Valley Hospital. We've had a very detailed clinical services planning process for the development of the Lismore Base Hospital. We're currently going through the process of a clinical services plan for Ballina, which incorporates the surrounds, and we have a clinical services plan in the process of being developed for the Clarence Valley, that's Grafton and Maclean. The only hospitals we don't have a clinical services plan going forward are the MPSs, and we recognise that oversight, and part of our work, when COVID allows, will be a broader health services, clinical services plan.
Thank you.
Thank you very much. I just want to ask you a couple of questions in relation to staffing. In your opening remarks, you did touch on the number of staff and the increased number of staff in the area. And obviously we've seen in the last 18 months with COVID, there's been a lot of changes and particularly probably this area we might have had people wanting to go back to other parts of Queensland or interstate. I just wanted to get an overview of how many people have resigned in the last sort of 18 months and where the numbers are up to now.
We have what we call a churn rate. We have about 75 to 80 people resign every month, and we recruit an equivalent 75 to 80 people every month. As you can imagine, any organisation, there's movement of people. What we do have is an astounding number of people who have been here for a very, very long time. We don't have a retention issue, but we do have people who leave because of job promotion, relocation and so forth. So you've had that 80, so that's 960 people turned over in a 12-month period. COVID has created further challenges. We can't step away from that. We've had people who have applied for positions from Queensland or from elsewhere in New South Wales, and at the last minute have been our preferred applicant. We've offered you the job, and they have declined. This is not a large number, but it sends a strong message. They have declined that offer based on the border closures because their elderly parents live in Queensland or there's someone important in Queensland and they don't want to be locked out. So the border closures have created challenges for us. In the initial border closures that was referred to by the Deputy Chair, we had major concerns over a short period of time in providing medical coverage at some of our facilities because a lot of the locums I was referring to that we use were coming from Queensland. So with the hard border lockdown, they couldn't come through. So every time there's a lockdown, we have a problem because I've got staff who work in my hospitals who live in Queensland and vice versa in Queensland. We've negotiated an agreement with Queensland Government and Queensland Police that when that occurs, there's sort of a secret roadmap that the staff have so they don't have to queue up in the long lines and they get through both ways. But it has created a degree of difficulty that is, again, I know I'm using this word too much, very unfortunate.
And I just want to move on to staff training and upskilling, because it was something that was raised by a witness one of the witnesses said this morning that I think application had gone in for upskilling and they were declined. Now, obviously, everybody can't be given upskilling training. I just wanted you to clarify what is the process for applications for people to be upskilled, but also to get support for study and being able to take leave, particularly if they wanted to go on and do,
Sorry.
Yeah, no, go.
Sorry. Can I answer directly the point, because that was a Bonalbo issue that was raised, and then I'll ask Catherine to comment more on the education side of it. That request was to upskill some registered nurses in X-ray operation, and having nurses doing plain film imaging, it's what it's called, is something that's not fully endorsed by radiologist societies or radiographer societies. We decline that partly because the local GP wants to take more advanced training and for him to do that work. We haven't said completely no to the nurses because we do see some benefit in that, but we're going to assess what happens with the GP and then revisit that further down the track. But I'll ask Catherine to answer the broader question.
So in regard to access to study leave and professional development support, there is a range of approaches that are taken. We have across the district a number of clinical nurse educators and nurse educators amounting to 71 full-time equivalent, and they work across all of our sites, and they support staff with clinically based education and skill development. There is also processes in place where staff can apply for support for study leave to undertake postgraduate studies, and also can apply for scholarships through various mechanisms and be released with study time to do that as much as possible.
And just in relation to the 71 clinical nurse educators, obviously they're spread across the region. Just using Lismore as an example, and maybe just a general surgical ward, how many, I suppose, clinical nurse educators would you have at Lismore, and how is that structured across different wards?
Generally speaking, you would have, in an average 30-bed ward, you might be looking at one full-time equivalent of nurse educator or clinical nurse educator, but it would depend on the need and how the education service was to be structured, what the specialty of that unit was. Other supports that were available, including clinical nurse consultants and nurse practitioners who also support staff development. So it's variable.
Yeah, look, I can say it was raised yesterday, so I'll put it that way. The availability of outpatient clinics particularly for chronic disease or the lack thereof, have you got built into your plans the provision of outpatient clinics for chronic disease?
We run a number of chronic disease management programs. Because of the nature of chronic disease, we have an outreach chronic disease management program, and so we work with people with chronic disease, respiratory groups, cardiology groups, just to name two as an example.
What about, for instance, rheumatology?
We don't run a rheumatology outpatient clinic. To be honest with you, we've never been approached to run a rheumatology outpatient clinic or a rheumatology program specifically, but we work, particularly the last couple of years, very closely with our general practitioners through the primary health network, where our chronic disease management team work with the GP practices who have those known chronic disease patients. We tend to know those people because we deal with them on a frequent basis. So we've implemented a range of programs to maintain their health, as I said, respiratory, cardiology, to name a few, but we also have programs to support chronic disease management through winter, what we call our winter plan, where we work with the GP practices directly and provide social planning, upskilling of their practice nurses with our experts going in and providing education and support, and that has been overwhelmingly well received, not only by the GPs and the practice nurses, but the feedback from the individual patients. And the one that really got me was, and I'd never even looked for it, thought this would be happening, that support has allowed him to have a more broader social life. And when I spoke to him directly, he said I was isolated at home because I didn't feel confident in going out, and the program now has given me the confidence to go out. So we do it. We also have a specific Aboriginal chronic disease management program because that needs to be culturally specific, and also work with the AMSs. So with our ageing population, chronic disease management is something we're fast becoming experts at.
Yeah, it seems to me that so much of the increase, we've talked about it on the bus and so much of the increase in population that's occurred in certain areas of the state, North Coast being one, I've got to say around Tamworth is another area where there's been a large movement of an ageing population into the area, essentially a retirement movement. And the question that arises from that is, are the LHDs sufficiently nimble to take into account this, what's essentially a changing demographic in the area?
Comes back to an earlier comment I made about planning. Having a document, in my view, a strategic plan that goes for 10 years is not very valuable. You need something that has a shorter period. For me, 3-4 years would be the most you'd want that plan, because it needs to relate to the changing demographics. We know that we've got a certain percentage of people over 65. We know we've got a certain percentage over 85, but we don't know how that's going to impact our healthcare delivery over the next 2 years. We do know that we're planning for it. If I use Tweed as an example, that's the most recent plan. Part of the redevelopment for TVH is a broader rehabilitation program recognising the age. We have enhanced our palliative care services recognising the aged, and the chronic disease management programs, value-based care programs that we're implementing, primarily looking at managing conditions of the elderly. So we are responding to that, and it depends on a raft of things. So we don't commit ourselves on a path for 10 years. You use the word correctly. We need to be nimble and respond, because we are seeing growth in population. I don't think it took me 6 months when I moved here. I'm not trying not to be flippant here, but it took me 6 months to meet anyone who actually was born here. Everyone had come from somewhere else. We're starting to see that again. A lot of people wanting to come. I hope that answers your question.
Yeah, thank you. Look, I'll move on to another area because I'm mindful of time. Ear, nose and throat specialists, how many are in the LHD?
Look, off the top of my head, I do apologise. I think we have...
Look, you can take it on notice. This is not a guessing competition, and it's certainly not a memory test.
Look, we have a roster at Tweed, and they had difficulty for a number of years in recruiting a complete roster for Lismore base. So we're still reliant on locums coming forward, but I can certainly get that detail back to you.
Thank you. Now, something that's reasonably close to my heart because of my grandson, what provision for the availability of ear, nose and throat services are there for preschool people, kids?
The challenge with that is that's what we would term a rooms-based service, accessing an ENT specialist in their rooms, and that's always been a challenge. There were some decisions made a number of years ago, David may recall when if you're taking tonsils out, which is often a young person's condition, the specialist needs to be around in case of complications for, I believe, now up to 10 days post-surgery, which makes it difficult in regional environments when you're relying on locums, because locums don't want to hang around not operating for 10 days. So our focus is on getting people to stay here and work here. We've had a modicum of success, but the market for ENT specialists in Australia is very difficult at this point in time.
All right, look, I'm not going to ask anything more because...
But sorry, just to clarify, to answer you, we do have good relationships with Queensland. I keep coming back to that. We work with our GPs. So a lot of the GPs now, through the meetings we have with them on a regular basis, we tell them the supply we have in a number of services, ENT being one. And if there's not enough supply to meet their demand, then they refer up to ENT surgeons in the Gold Coast.
Look, I accept that. My concern was in part the evidence that we received yesterday from a young woman. It's not the experience that my family has had, but things are different in different circumstances. But her story of accessing appropriate services for her daughter involving travelling to Newcastle, single mother. Very concerning. Like, she coped, but my feeling would be single mother, other children, accessing services 2 hours away is likely to see that child, or many of those children, get no services at all. So, I get the model for adults, but, it really is a concern to me when you see those stories involving young children and whether we're doing enough.
Agree.
Can I just, you make a comment that there's a supply and demand issue in relation to ENT surgeons Australia-wide. Why is that?
Look, I couldn't answer that in too much detail. I'm not across it. All I can tell you is that ENT surgeons in regional, but also in some metro areas, are difficult to attract.
Yep.
They're very, seem to be less difficult in attracting them in the private sector than in the public sector. And most of them do work foot in both camps in that regard. But all I can say is we've had difficulty for a number of years in recruiting to permanent positions, either VMO or staff specialist for ENT surgeons.
So the argument in terms of Tamworth was that it was the inadequacy of access to operating theatre that was preventing. Now, whether this is right or wrong, but it was the adequacy or inadequacy of access to operating theatre time that was preventing an ENT coming to Tamworth. Is that potentially an issue in your LHD?
Not at this point. I would have said 5 years ago, potentially, because of capacity, not for any other reason. But we've, part of the redevelopment of the Tweed Valley, or the building of the Tweed Valley Hospital, was to do some work at Tweed Hospital to keep it safe and operating for the building period. Part of that included 2 extra operating theatres, and the Lismore base has got capacity up until, I think, 2028. So we're using, I think at last count, 8 of those theatres. So no, access to operating theatre is not the challenge to us. And we've got operating theatres in a number of our facilities. Again, we network services. We don't want everything to come into Lismore because it defeats the purpose of trying to decongest it. So where it's clinically appropriate, we have a number of surgeons, orthopods and general surgeons, who do a lot of their minor work out in our peripheral hospitals.
Am I back on?
You're back on.
Can I just, before we go on, just looking at the time, may I suggest this? It's about just 11 past. Could I suggest 2 lots of 10 that would get us through to 3:30, and another 5 to tidy up if there's a need to do so?
Yeah, look, I'm happy with that. Yeah. I suspect there won't be any time.
No, Mr. Chair, I probably won't even need my full 10. I'll just
Well, I've got some questions, so
good.
I'll-
Okay. So then I'll just... I'm a fibber.
It's going to take 12 minutes.
Mr. Jones, I'll take you back to some questions earlier about COVID impact on New South Wales, Queensland border relations. So would you admit or would you recognize that COVID highlighted an over-reliance on sending people across the border to Queensland for specialist treatment that should have occurred here?
Not so bluntly, I wouldn't, but please let me explain.
Okay.
We do recognise, as I said earlier, 4 or 5 years ago, elective surgery may have been difficulty to access because of capacity. We've dealt with that. So a lot of the planning now, we have a very deep and broad range of medical specialists in our larger hospitals. So it's not so much accessing that. It's more coming back to the quality and safety component of networking services. We are, the border should not be seen as a negative going across it, because the proximity to super specialty services at the Gold Coast that people in the North Coast can access that other regions in New South Wales cannot. It's a difficult time to travel across, but the time is not that great, if I'm really direct on that. So, no, I don't think it is, but I do recognise we will continue to send people up for super specialty services because we won't be developing them, because there's a risk of having low volume proceduralists here. We don't want to do that. We've seen the benefit of centralising. Cancer surgery is a classic example. The mortality and morbidity improvements associated with centralising into bigger facilities where people do more surgery is just proven in that regard. But what we will see with the enhancement of both Lismore, Tweed and Grafton when it's developed, and Ballina, is more capacity for what work we can do. So we will see a return back, as I said earlier, about 5,000 people we anticipate.
I'll take you back to Lismore-based hospital. Are you confident that junior doctors are getting the appropriate supervision?
Yes, I am, and I base that on a number of counts. We get a number of audits being done. AMA is an example, do an audit of the training programs, and the service came up very well in that regard. The JMOs themselves felt there was good supervision. Lismore in particular, we work with the University Centre for Rural Health and have a training hub through there. So there's a great deal of support for the JMOs there. And we have a dedicated group of senior clinicians who take training very seriously, and they pride themselves in moulding the next generation of surgeon and physician. So long-winded answer, I am very comfortable.
Now, you wouldn't be aware, but we've had evidence to the committee that doctors have expressed concerns about working unrealistic periods of time, we had evidence that one doctor claimed that there were doctors that had worked, Mr. Trevor and I had an exchange of 96 hours continuous. Are you aware of those claims?
I'm aware of the historical comments being made, and I use that term deliberately.
Yeah.
There's been a number of systems put in place by New South Wales Health to prevent that. We do not want our JMOs, who are the backbone of the delivery of care in a hospital, fatigued. So the old days, and I think we need to recognise it was a practice where JMOs worked extended hours. Now it's up to, we roster them, we audit the rosters, we check, because sometimes you could swap your shift and we think you're okay, but then all of a sudden you've swapped and haven't told anyone, and you could have worked extended periods. We work with the JMOs not to do that. So there has been incredible improvement in ensuring JMOs are not fatigued by overworking them.
This morning we heard evidence from George Thompson and of Korakai and the Residents Association there about the Health One facility. Is the local health district taking any steps to help secure a doctor for the Health One facility there?
Look, we've taken a number of recruitment rounds. There's been limited response. When we have had response, we've tried to make the package exceptionally attractive. We pay the outgoings, we pay for the administrative staff. We put a lot of financial incentives in there to attract GPs. I think George mentioned this morning that the volume of activity doesn't meet the business model that anyone's come to. We even went to one of the corporates, which is against my DNA to do, and they came and had a look, and they couldn't see any benefit in doing so. We've approached the GPs in surrounding areas such as Casino, which is about 22, 23 minutes away, and see if they would support. There is no support. We will continue to work with the local community, but also with the primary health network, recognising that I do recognise that general practice is a Commonwealth priority, but the reality is this is part of our community, so we work with the agencies, including the Commonwealth PHN, to try and get a GP. We will continue to try, but we are struggling in getting someone into Korakai.
Mr. Chair, I'll end on this question here. Taking you back to some questions I asked earlier about the MPSs, are the 4 MPSs that have, several nurses working on the weekends and that, do you have security staff on those hospitals to assist? Because we've had evidence from other rural other MPSs in rural and regional areas. There was concern from nurses about their security.
No, we don't. We have, when the opportunity arises, we employ health security assistants, and we've got 1 or 2 of those in Kyogle. The tenure of those positions in the MPSs doesn't allow us to do that, but we do, when we replace them, look at those as an option. What we do in lieu of that is design the buildings or modify the buildings to create security. So we'll say 5 o'clock as a point in time when the staffing numbers reduce. And what the process then is, the MPS is locked down. Someone goes around and checks that all the access point bar 1, and that's the main entry, are locked. Even then, that main entry is locked under you press a button to open the doors, and that allows the visualisation of someone walking up to the MPS, and they decide that person looks a bit, I don't know that person, what risk they're going to provide, and they can intercom them in that regard. So, long-winded answer, no, we don't have security staff, so we operate through processes and systems.
Mr. Chair.
Mr. Jones, I'll ask you this question, and can I ask it this way? I'll ask it in the third person, if I could describe it that way. So it's a vicarious way of sort of asking you, but to imagine this. But assuming a few weeks' time there was a gathering of the LHD CEOs all around New South Wales, part of an annual gathering. So you'd had a busy day and got through all the business on the business paper, and you'd had dinner and then broke to the bar for a few drinks. Had a couple of drinks and sharing things. And someone said, listen, what can we do to really improve palliative care in New South Wales? We're the CEOs of the LHDs. We have a pretty good knowledge through that, directly and indirectly, about matters to do with palliative care, and not reflecting on any LHD or any CEO, just the history of how we got to where we are with respect to the understanding and the delivery of palliative care. So I'm talking about very end stage. I know palliative care can have a long tail depending on the individuals, but I'm saying literally the hours or days before death. What would that CEO say, who was sort of reflecting all of that, about what could be done to take a step up, not overnight, but moving towards a better way in which we can deliver palliative care to the citizens of this state? So it's inviting you in a cheeky way to be sort of frank. It's not reflecting on you personally, I don't want you to take it that way, but rather what could be done holistically by New South Wales Health to step up the way in which we deal with end-of-life care in New South Wales?
I cannot recall which minister instigated this, whether it was the current Minister Hazzard or his predecessor, Minister Skinner. But there was a focus on workshops for palliative care in regional communities, bringing the community, the non-government providers and the government providers together. And that certainly identified varying deficits. Everyone had a deficit, it just varied on what it was. So there's been a strong injection of resources and thinking about palliative care, and I can only comment on my patch at this point in time. We worked very closely with an agency called Silverchain, who were doing a home-based palliative care program. That model has shifted. They provided excellent care, let me make that clear on record. They were very, very professional and very capable, but there was always a degree of disconnect with our services. So the decision was made where we had the opportunity to look at bringing that service in-house, which we have done. So we've increased the number of specialists. We have 3 palliative care specialists now. We have a range of community services. And I think the improvement we've had, we now communicate well with those providers. We support through financial funding the only hospice we have in our footprint, Wedgetail. We work a lot more with our general practitioners. And so I believe the system has improved dramatically. We've got palliative care nurse practitioners and so forth. Where can it improve? I think to continue to work with people and families who are going through that journey and give them the choice of where they wish to die. So we do that, and we do it quite well, but I think if there can be an improvement, it's ensuring that communication is there so people don't feel anything other than it's their wish to where they wish to die, in a hospice, in a hospital, or in their home. I think that's the next quantum leap, because at the moment we talk to people and we believe that whilst there's greater choice there for people to select where and how they die, then we need to make sure it's even more, because we do get some feedback that mum died in hospital, but wouldn't it have been great if she died at home? And then we ask, why did that occur? We're creating environments in most of our facilities. Recent funding's allowed us to refurbish and develop palliative care rooms in a number of our hospitals, so it doesn't look, you want to die in a hospital because you don't want to leave that challenge of managing the body at home, then it's as homely a place as possible. But there has been a lot of investment, a lot of energy in palliative care. I think the next step is recognising end of life and giving people the choice about end of life, but that goes into a political sphere that I will refrain from commenting on.
Yeah, I think Greg and I have got a different view on that.
Yeah, maybe precedent.
Perhaps for another day. Thank
Another
you.
inquiry.
As long as I'm the chair, that's all. We can organise that, Greg. Maybe there'll be a chair and a coach. I don't know how it's going to work.
Thank you. I've just got a couple of last questions. Just to follow up from the questions about Korakai, you mentioned that you're going to continue to try to recruit a GP in the area. Well, I mean, where do we go from that? I mean, if that just continues on and on and on, obviously there's been a lot of witnesses come here today saying that, just trying to recruit somebody, it kind of leads to nothing, and something else needs to be added to that to kind of incentivise them. What are the next steps if that continuing recruitment process leads nowhere?
I apologise if I'm mishearing your question, but I think you're leading towards, is Korakai looking at an MPS model?
No, it was more of an open question to
so
say, well,
let me talk
where do we go?
Let me talk about why it's not an MPS. Because when the planning phases, the options with the community fell down when the, no pun intended, when the hospital was damaged, was Health One or an MPS. An MPS is a combination of federal funding for aged care and state funding for acute community-based care. And the aged care facility at Korakai did not wish to change. They did not wish to segregate from their current organisation and join an MPS. Benalbo Uniting Care, which was behind the old Benalbo Hospital, were comfortable to relinquish the licences back to us. So that allowed an MPS model. So that's why it's a Health One as opposed to an MPS. Look, I wish I had an answer that would satisfy people like George and the people of Korakai, who we meet with, on occasions to talk through it. We'll continue to work with the PHN. I think there needs to be some changes to the remuneration models, and that involves Commonwealth changes as well as state changes. It needs to be attractive. It needs to recognise that it's not a business based on volume. Some of the communities, and Korakai is the only one I can speak to, will not generate a great deal of income for a GP based on volume. So there has to be some further incentivisation. So I think the next step is to sit down with the Commonwealth agents through the PHN, Healthy North Coast, and they're very committed to this. I want to put that on record. They've supported and tried to get a GP as well. Is there something between us that we can do that's novel? Because there is a need there. I'm not stepping away from the fact. GP services are only 22, 23 minutes away from Casino and Lismore and Evans Head. The reality is it's an ageing community, and a local GP would be an outstanding outcome.
Yeah, definitely. So you think that the main incentivisation would be financial?
Look, there's a lot of studies. I'm sure you've learned people are across these that remuneration is not the primary driver of why people take a job, but you need to earn a living, and so it needs to be a whole range of benefits, and it won't bore you going through, I'm sure you've read them, but we need to ensure there's an adequate income for those individuals, to maintain a quality of life. And what we do know is having a single GP in small towns is a model that is dying. It's not something that lends to a quality of life, and hence people are stopping it. And there is a challenge in getting multiple GPs with the workforce to go and provide that roster that's required. But we're going to have to look at something, because in places like Corokai, it's a challenge for us dealing with the community, because what we do recognise in regional rural, despite the fact that when you sit down with communities and say GPs are funded by the Commonwealth, yeah, but what are you doing about it? You know, we are the face of health. So we could put our hands up and say the Commonwealth problem, but at the end of the day, they're residents in our footprint.
We also heard from a number of witnesses that required different and had different health issues, were actually considering leaving the area because of their concerns around the health issues. Is that feedback that you have also received, that people are now moving out of the area, and are you concerned that that's going to continue to happen with the current state of play within the healthcare system?
Look, I don't want to dismiss the concerns. The gentleman's talking specifically about neurology and neurosurgery.
There were others as well.
But I'm just saying that in this case, neurosurgery won't be provided here because of volume and quality and safety concerns. Neurology, we've had challenges. We have a neurologist at Tweed, we've got a neurologist in Ballina, we've had trouble in Lismore, we've got someone starting in the middle of July, which helps. But what we're seeing is more people coming to us than leaving us. And it's our job as an organisation to recognise we can't provide everything in your own backyard, but it's our job to ensure that when you need it, we can escalate and transfer you to get that care that's required.
Thank you.
Thank you, Chair. I just wanted to touch on the Aboriginal Health Unit, if I can, Ms Duffy. Within the, so I understand, I've got the Aboriginal Health Unit page here in front of me. How many workers are within, Aboriginal workers within the LHD are there?
I don't think I can answer that off the top of my head, so we'd have to take that on notice unless Wayne has got that figure to hand.
Look, it fluctuates, and at this point in time, we have a very low number, there's about 18, but that does fluctuate, but we're happy to get the actual figure and bring it back to you.
Yeah, that would be great. The positions, if you like, and then the filled positions. I understand there's probably potentially some vacancies, like there seem to be in a lot of different areas.
Only a very small number at the moment.
Okay.
But we do have some movement from time to time, but there's not much in the way of vacancy right at this point in time.
But can I add what we're doing about that? Because it's a piece of work that we've been working on for a number of years. We're very fortunate to recruit a woman, Indigenous woman by the name of Kirsty Glanville, who's our Associate Director of Aboriginal Health. And when she came to me, her previous employer contacted me and said, well, be careful because she will hold you to account, and she does that very much so. We've commenced an Aboriginal Employment Recruitment and Retention Officer. We have an Aboriginal Employment Plan. We're about to be the only LHD in Australia that works with the ARCHO, Aboriginal Controlled Corporation, to work also with the Indigenous Allied Health Association and have Aboriginal cadetships for allied health, permanent positions going forward. We're looking at culturally sensitive ways in which we can retain workers. We've tried in certain circumstances, and the one that comes to mind is having an Indigenous sexual assault worker. That failed, because having a single Indigenous sexual assault worker provides them no cultural protection. So we need to look at, if we're going to employ one in an area such as that, we need to employ two. So there's a lot of work going on. That we are very confident that we meet the number target that we try to achieve, but we want to have 5%. 4.2% of people in our LHD are Indigenous. We want an employment target of 5%. We're very committed to the fact that one of the best ways to deal with the adversity and disadvantage is employment.
Because I was going to ask about the target, the workforce target, that 5%, which is great to hear. Is that by a particular year?
We're trying to do that within 12 months.
Okay.
To be, because it is ambitious based on where we are at this point in time. But we think there's a range of services, and we're not just saying low-level roles. We just don't want Indigenous people coming into. There needs to be a career path. Coming back to the comment earlier, how do you attract and retain people? The clear evidence is have a pathway. So they don't see that I'm not just going to be the cleaner, I'm not just going to be the allied health, technician, I can be a whole range of services. So we're very committed to that. We're very fortunate that all the MPs of all colours, federal and state, are supporting us in this, and we work with our other major employers. We've invested in a position to work outside of health to develop an Aboriginal employment and recruitment and retention program for some of our other major employers in the area. The Meatworks is one example. So we're very committed to this. We've invested in it.
Thank you, Mr. Jones. That's good to hear. Ms. Dovey, can I also just ask about Aboriginal birthing units and or midwives and what that looks like within the LHD? We've heard, I think it was Wellington. Was it Wellington? I'm getting about the Aboriginal midwife there who was talking to us about the importance of having. Well, firstly, the fear sometimes of the whole, for obvious reasons, of the hospital environment, but then how important and essential a role she was playing for pregnant Aboriginal women in that area. Is that the case here? Do you have Aboriginal midwives in the LHD?
Yes, we do. We do. And that does fluctuate, and we work closely with our maternity services in ensuring that there are culturally safe and sensitive services provided to these women. So it continues to be an ongoing piece of work. And certainly Kirsty from the Aboriginal Health Unit perspective is involved in that in terms of how we work with the community to provide those services.
Okay, and if that could also be provided within, I assume, the positions as to whether they're full-time, like whether they're permanent, what that looks like as well, that would be great. So I was about to say that's it for my questions, and there you go.
Okay. Did you have one more?
No, I didn't.
No. Well, thanks, Kate. Well, that brings us to conclusion, but deference to the government. Well, we haven't been hard enough with our questioning. The government.
Oh, no, you have.
I think
Can we get a vote on
quality of the witnesses? Hard enough. Well, listen, can I just conclude by thanking you all individually very much for coming along. We know that your responsibilities are high and your time is precious. But you made the plus this afternoon available. We appreciate it very much. So, thank you, and can I thank you on behalf of the committee for the outstanding work you do for the citizens of Lismore. Doctor, obviously, as a medical practitioner, no doubt, on the tools, so to speak, and of course that work is greatly appreciated. And of course, the administration is widely important. So, both to Mr. Jones and thank you very much. So that concludes our hearing for this afternoon, and we'll conclude our matter there. Thank you.
Thank you very much.